hip and knee. The Indian Arthroplasty Association is having now the present membership of 745. And today we have our webinar on performing a well-done total knee arthroplasty, minimizing unhappy knees, convened by Dr. Devabrata Padhi from Bhubaneswar. It's a very, very important subject, and I hope that our colleagues will be much help with this. It will be interesting discussion. We have a very interesting faculty, very well-known faculty with us. Indian Arthroplasty Association has been doing the webinars for last almost 1.5 years. This is the 26th webinar today. And every month we have one webinar. And we are happy to announce here that October 7 and 9 is our annual conference at Coimbatore, which will be a action-packed, very much academically oriented meeting organized by our secretary, Dr. Rajkumar. Today's webinar is on performing a well-done total knee arthroplasty. We have very renowned faculty, Dr. Briard from France and Dr. Han from South Korea, and our very eminent arthroplasty surgeons from India. This webinar is being seen by our friends from abroad as well. And I hope that we all will be learning a lot during this course of the discussions and presentations. I'll request Dr. Devabrata Padhi to introduce and initiate. Deva, please.
Thank you, sir. Good evening to you all. Welcome to this 26th IAA 360-degree webinar. This webinar is, after so much discussion, we have come to a conclusion that we should go to the basics. So in this webinar, we have very eminent faculty. 3 are from outside India. So I will introduce them first. First of all, Professor Jean-Louis Briard from France. He is a very eminent professor, and he has 50 years of experience with lots of publications in his name. So he will be speaking on aligning the valgus knee. And then Professor S.B. Han, he is the director of orthopedics in Korea University Medical Center in Annam-dong in Seoul. And he is now the vice president of the institution. So he has a lot of experience in hip and knee arthroplasty, along with the computer-assisted navigation. He is a training, he gives training in that. So apart from that, we have Pradeep, who is now in Australia, and he's there for the last 1 year now, and he will be speaking on managing extra-articular deformity. Apart from them, we have our eminent, very senior surgeons from India, and we know all of them. They don't need any introduction, but for the sake of introduction, I am just enumerating their names. Professor Dr. Rajesh Malhotra, he was the past president of IAA. Dr. Anup Jurani, then Dr. Vijay Bose and Dr. Harish Bende, they were past president of the Indian Arthroplasty Association. And apart from them, there are Dr. Ramnik Mahajan from New Delhi and Professor Abhay Alliance from Jodhpur. So these are the faculty members, and I thank again our president, Dr. Rajiv Sharma, to give this opportunity to me to convene this webinar. So as we know, friends, recently in the recent years, the number of arthroplasty cases have increased a lot. So in India, as the population is more, the number of cases, primary cases, have increased. And this increase in primary cases has led to the chance that there will be more need of revision surgery and the chance of failure in the primary cases. So for this, when a lot of young surgeons are going into arthroplasty, we at the Indian Arthroplasty Association, we are dedicated to the arthroplasty education in the country. So for this, we have decided to go and sit back and discuss basics, so that we perform a TKR in the best way done so that the chances of failure will be minimal in these cases. So with this, I will not waste time any further, and we'll start up with Dr. Anup, who has already started sharing his screen. Thank you, sir. So he will be speaking on perfectly doing a tibial cut in a primary TKR. Over to Dr. Anup, sir.
Hello, good evening, everybody, and thank you, Deva, and thank you, Dr. Rajiv, for this opportunity. And this is a very basic presentation, and we'll stick to basics as asked by Deva. So, first, a few elementary issues. The tibia cut is aimed at 0 degrees of the mechanical axis, and the anatomical and mechanical axis is mostly the same in most tibias, but not in all. And we'll discuss what happens in a varoid tibia and a valgoid tibia. But theoretically speaking, the mechanical axis and the anatomical axis is the same, and we need to take a perpendicular tibial cut at 0 degrees, and we'll discuss more about the slope. Now, tibial cut affects, we all know this, the flexion and extension gap both, because it articulates with the distal femur condyles in extension and the posterior femur condyles in flexion. Now, this has a bearing on the way we cut our tibia. And if you increase the tibial slope, you can actually selectively increase the flexion gap. So if you increase the slope by 2 millimeters, you will increase the slope by roughly 2 degrees. We'll discuss more about that in a moment. And the anterior tibia is the major contact point during extension, and the posterior tibia is the major contact point during flexion. So the tibia cut is really important for all loading kinematics of the knee and for long-term survival of the knee. Now, tibial cut can be divided or can be understood more into all 3 planes: the coronal plane, which is varus and valgus part of the tibial cut, the sagittal plane, which is the slope of the tibia, and the thickness of the tibia. All 3 are very important, and we need to understand each of them in its real basics. Now, how to take the tibial cut correctly? We prepare the femur first, then sublux the tibia out. You can do the tibial cut first, but in stiff knees, in tight knees, in knees which are rheumatoid with severe fixed flexion deformities, it may be difficult for you to sublux the tibia without doing a big soft tissue release. So we prepare the femur first, then hyperflex the knee and protect the medial collateral and the lateral soft tissues by respective hormones. So this is our position for tibial cut. We'll navigate or do robotics in all our knees, but I'll just pass on the lessons that we have learned from navigation and robotics for conventional surgery. So I'll just give the steps of the operation of the tibial cut especially, and how to get it right every time without navigation. So you can see that this is the way we take our tibial cut. Medially, we don't put any homen because MCL is really a pristine structure, needs to be preserved all the time. So we just have a blunt protection instrument medially. Laterally, we have a homen. The femur is already prepared, and we have a posterior homen which brings the tibia out at the end of the surgery, at the end of the femur preparation. Now, the current techniques all involve making tibial cut parallel to the tibial anatomical axis. But we need to remember that full length X-ray is a must to analyze the tibia, whether it's a varoid tibia or a valgoid tibia. And varus in tibia is really poorly tolerated. And you may have most failures that we see today in knee arthroplasty at 5 to 8 years are because of varus tibial cuts, more than 3 to 5 degrees, leading to overall mechanical varus alignment and early failure. So varus tibial cut is a strict no. And valgus tibial cut may look poor on the X-ray, but is still better tolerated. Now, for tibial cut thickness in knees with fixed varus deformity, more bone is resected from the lateral plateau than the medial tibial plateau. And we need to, if you're doing conventional surgery, then you need to really have a fair idea of that you will not be resecting anything from the medial side if there is complete cartilage loss. So there will be 0 resection or minimal resection from the medial side and 6 to 8 millimeters from the lateral side. Always cross-check with the stylus for thickness. And in varus knees, that we'll discuss now, take measurement always from the lateral tibial plateau. And in valgus knees, always from the lateral plateau also with 0 or 1 millimeter resection from the lateral side. Now, posterior slope is not the same for all patients. If you follow the rule of 2 to 3 finger breadths at the base of the jig, you can see here that it's giving a slope of 3.5 degrees. That's the slope that I'm talking about, 3.5 degrees, where 3 finger breadths. Now, all tibia are not the same, and all tibial slopes hence are not the same. Now, similarly, in this patient, you can see same 3 finger breadths, the slope is 6 degrees. So you need to see the X-ray very carefully, look at the X-ray very carefully and titrate the slope accordingly. Hyperextension, recurvatum knees usually have a neutral slope. Valgus knees have lesser slope. Severe subluxed varus knees have more slope. So you need to titrate the slope of every patient and not follow this rule of 3 finger breadths from the base of the jig in every patient. And it will vary. As you can see, here it was 3 degrees in one case, 6 degrees in another case. Now, coming to individual cases, now this is a varoid tibia. You can see that here, if we pass the anatomical axis and the mechanical axis, not the same. So the anatomical axis will pass from the center of the tibia to the center of ankle, but mechanical axis will pass medially. So this is a varoid tibia, and we need to understand that for a varoid tibia, we need to medialize our jig much more. Now, conventionally, if you put your jig like this, like you do in every case without seeing a full length X-ray, you'll see that you are in 3 degree varus. Now we cross-check with navigation and you are in 3 degree varus. So the point I'm trying to make is that even if you're using conventional surgery, this message I'm extrapolating for all of you who do conventional work, that for a varoid tibia, medialize the jig more. When you medialize the jig more, then you are in a degree of varus or 0 degrees, whatever you are shooting at. But if you are medializing just one mark there, like in every case with a varoid tibia, your tibial cut is going to be in varus, and the overall mechanical alignment will be in varus. So it's extremely important to medialize the jig more in a varoid tibia. Keep the tibial cut minimal thickness. So we discussed the slope, we discussed the coronal alignment, varus, valgus, and the slope. The thickness of the cut is very important. One should resect only 6 to 7 millimeters of tibia in a severe varus deformity, because when you release medially, you will be able to put a minimum 9 millimeter poly. So the aim should be to put a 9 millimeter poly in every case, or minimum thickness poly in every case that you're doing. And the trick for that is to resect 6 to 7 millimeter in a female, 8 to 9 millimeter in a male. Now let's look at a valgoid tibia. Now this is a valgoid tibia. You can see that this is a valgoid tibia. Now here you have to go just converse what you saw in the varoid tibia. Now again we cross-check with navigation, and you can see that by putting the jig where you'd always put it in a valgoid tibia, your tibial cut is in valgus. You don't want that. You want your cut in a valgus knee to be in a 1 degree varus. So there you need to lateralize your jig to cut in varus. So please understand that in a varoid tibia, you need to medialize more when you're doing conventional surgery to prevent a varus tibial cut. In a valgoid tibia, you need to lateralize the jig so that you can cut in a degree or 1.5 degree of varus to get your overall alignment right. So there you can see that the jig is now lateralized in a valgoid tibia. And usually the medial side is more or less equal, or the lateral side you'll cut 0. So measure from the lateral side, because if you measure from the medial side, in a valgus case, you'll cut too much more bone. So put your stylus at 0 millimeters and cut 0 from the lateral side. You'll cut 6 from the medial side, and that should be sufficient for you to put a 9 millimeter poly after soft tissue balancing. What about obese patients? Obese patients are a different. With obese patients, the landmarks are difficult to palpate, whether you're doing conventional or with navigation. So you need to have thin drapes, just a layer of opsite, no stockinette, no nothing, just a layer of opsite and one glove below the ankle, so that you can palpate the landmarks very carefully. An obese patient, if you do a varus tibial cut, it's going to be a disaster, absolutely. So one needs to have a perpendicular tibial cut, and the trick again is to palpate and check with navigation or check with robotics. But if you're not doing that, then again, you need to palpate them very carefully and ensure that your tibial cut is not in varus by medializing the jig a little more. Again, in obese patients, the gaps are loose. The patient is obese. There is soft tissue laxity. Your cut can be 5 to 6 millimeters, and that should be enough for you to put a 9 millimeter poly. You can always retain the tibial pins and come back with a plus 2 millimeter cut if you need to. But your tibial cut in most severe deformities should be conservative. What about extra-articular deformity or non-union of stress fractures, which is a common problem in our country? Here you need to do a different trick. You need to break the non-union and use an intramedullary jig. We use navigation, but apart from that, use an intramedullary jig to get your tibial cut perfect. So for non-union situations of tibial stress fractures, you need to align the tibial first, get an intramedullary rod in, and then take a good tibial cut. So the summary is that take full length tibia x-rays, full length femur tibia x-rays, good scanograms. In varoid tibia, medialize the jig. In valgoid tibia, lateralize the jig. That's on the coronal plane. The slope also analyzed properly on every. Acrovatum knees have got neutral slopes and severe deformities have got more slopes. So titrate the slope individually for every patient. And the thickness has to be minimal, 6 to 8 millimeters in females, especially obese females, and 8 to 9 millimeter in males. So that's the planning the tibial cut in all three planes, the coronal, the sagittal, and the thickness. And for obese patients, again, the cut has to be minimal and just avoid varus tibial cuts. Thank you very much.
Thank you, Anup sir, for sticking to the time. So I will request all the faculty to stick to our time of 8 minutes. And after that, we will have a discussion for 2 minutes. And I request all the participants who are in our Facebook link or YouTube link or directly in the Zoom to write their questions in the chat box, whichever platform they are in. And I introduce now to Dr. Vikas Kapoor. I had forgotten to introduce him. Sorry, Vikas. He is also a part of this program. And then I will request Dr. Ramnik Mahajan next. Any questions, Dr. Rajiv, in this in our platform?
Anup, I must say it's a very detailed and well explained tibial cut with various severe deformities. One thing, Anup, for the benefit of the younger colleagues, what is your point of reference proximally?
He means the tibial spine. Do you mean
yes.
that?
Yes.
Yeah, so it's in the center of the tibial spine, but that's only the proximal part. The real trick goes below the jig, because if you medialize, you can cut in valgus. If you lateralize, you will cut in varus. So while you are aiming at the center of the tibial spine proximally, the placement of the jig distally really makes all the difference, because slight error there can preclude the tibial cut into varus.
Very well explained, Anu. Just if I may elaborate it a little bit, the one way could be that you put a cautery mark on the medial surface of the lateral of tibia, and usually that will be the proximal reference point and center of the tibia distally. And rest what Anup explained very well, how to avoid the varus cut and how to avoid the valgus cut.
Anup, there is a question in the chat box. Somebody has asked a good question. Does preoperative tibial slope is important, and does it need to be reproduced? And if yes, up to what level you reproduce it? It's a good question.
Very right.
That's a great question. That's a great question. Well, you can measure the tibial slope in every case, but it's difficult to replicate it because your flexion gap will dictate what tibial slope. Suppose the knee is very loose, you may actually reduce the slope, and if the knee is tighter, you may increase the slope. So 2-3 degrees up and down, the normal anatomical slope is fine, but it should never be anterior slope. That's absolute no.
Sir,
Anup, another question on the chat box. Dr. Nitish Kohli has asked how to check that tibial cut is perpendicular to the mechanical axis.
Yeah,
After making the cut, how do you make sure?
so for conventional, you put the tibial tray and put the rod and palpate the tibia and see that it's pointing right between the first and second toes. If it's pointing toward the third and fourth toes, definitely you are in varus, and that should be avoided.
Right.
There is another question. How exactly should we medialize the jig to avoid varus cut in a varus tibia? As you told, we medialize and lateralize in varus and valgus. So how exactly you know that how much to medialize and how much to lateralize?
Right. So normally every mark is 3 millimeters. So normally in a straight tibia, you will medialize one mark, that is 3 millimeters. That is when you hit the center of the tibia, just below the malleoli. In a varoid tibia, you should medialize 1 or 2 mark more. So you should medialize 3 or 5 millimeters more to get a perpendicular tibial cut.
Another question is that if inadvertently, if somebody has done a varus or a valgus cut, so how to rectify it? It should be freehand or it should be...
No, I would not suggest freehand, at least in the initial stages. Unless you are using navigation, then you can freehand and check it. But I would not, then you better put the jig back again, take out one drill hole, put the jig back again and cut little more if you are in valgus.
In the meantime, in the interest of time, can I request Ramnik, please share your screen while we are still discussing about the interesting aspect of tibial cut.
So any difference in the tibial cut in CR and PS knees, as we know that there is difference in slopes in CR and PS knees for the benefit of the young surgeons. Anup sir.
Very good question. CR knees will need 7 to 8 degrees of slope. PS knees generally 3 degrees of slope. Because CR you need to mimic the posterior cruciate kinematics.
So we'll move forward. The second talk will be by Dr. Ramnik Mahajan, and he will be presenting on the distal femur cut, which is the second part of a TKR procedure. Dr. Ramnik, please.
Thank you so much for inviting me here. Thank you to Deva and Dr. Rajiv Sharma, and welcome to all friends. So without taking much time, so we're talking here about the distal femur cut. We already had a very interesting talk on the proximal tibia. Now coming to the distal femur cut, we know that distal femur cut is affecting my mechanical alignment. It is affecting my extension gap. And of course, it affects my joint line. How much of distal femur cut I cut definitely works on that part. Coming to mechanical alignment, what is happening? We all aim for a neutral alignment, a tibiofemoral angle around 6 degrees of valgus. Of course, we have a range from 5 to 9. You cut your tibia at 0, which we just heard. And most of us who are doing conventional, we are talking of an IM jig used for the distal femur cut. The difference between the mechanical and the anatomical axis, I like to calculate on our pre-operative X-rays. We have long HKA films, we calculate, and that is probably what we aim for. So not all patients get 5 degrees of valgus or 4 degrees, depending on if I don't have an HKA X-ray or a long film X-ray, then a standard rule is a coxa valga gets a lesser valgus and a coxa vara gets a more valgus. So you always do a pelvis with both hips. But it is a good idea to take long films, and you know what we are talking of on an average is 7 degrees. This is what we normally do in our center, is that we take all long films. We plan our cuts as per these long films, and depending on that, you know that we have to take a 7 degrees of valgus in this patient. And that's the post-operative X-ray without going into the details of the steps. And see, we have been able to reproduce what we started off with. And that is what we aimed for in the first place. For what? For longevity of the implant. This is after you've taken the tibial cut. Anup has already given us a beautiful talk on that. And here is what I see on femur. So where do I make my pilot hole? I make my pilot hole, which is slightly medial to my right side line, where just above 2 to 3 millimeters above the attachment of the PCL. And then remove all the osteophytes, protect my MCL. I put a retractor in between the MCL and the distal femur and remove all osteophytes. And this is what my planning says. I have calculated a valgus angle. I know I'm going to put a rod into that hole. Now comes the problem. The challenges are most of the companies give us stiff rods. And when I put a rod inside, I have calculated a 7 degrees of valgus. I put in my rod, and the femur could be something where the rod goes and hits the lateral cortex instead of going right into the center. I plan my cut of 7 degrees of valgus. I have a wide canal. The rod has a tendency to keep moving. So my aim is that I want to go in right into the center without hitting the cortices. And what do? Either I try to rotate my IM jig slightly, because all of these IM jigs are very thin. So you rotate it slightly to get a fit into the isthmus, so that you have stuck right into the isthmus, so that a cut which can be 5 degrees or 7 degrees on one side actually ends up as a perfect 7 degrees. So that is what I aim for when I go in. One of the company now has brought in flexible rods. It's a very good idea when if you have a flexible rod, it can actually negotiate in and get you right where you want it to be. And that's the 7 degree cut. Another patient, why we like to do all these HK films, long films, is because India, we have a lot of osteomalacias and a lot of femur vara. And look at this particular patient, with the right side is femur vara and the left side is a normal fan. So I calculate my balance, and so it is not 7 degrees or on one side, it could be 9 degrees, but when I incorporate the femur vara, I probably would end up putting a 5. And so that is what I aim for, and I plan it accordingly. If not, this is what you end up with. This patient actually came for a revision because both sides there was femur vara. A standard, probably a 5 degree cut would have been taken, and this is what the patient landed up with. Now, when I talk of anterior, we also have to look at lateral views. And a femur has an anterior bow, and that anterior bow, that's my rod going in, that's my distal femur cut. I have to plan my distal femur cut also based on the anterior bow. Otherwise, I will not have this kind of a fit. So this is the lateral view of the same patient which we started off for 7 degree valgus, and that is where I want to aim. So this is what the lateral view would then look like. A rod going and can either hit the anterior cortex, does not go into the center where I want it to go, or it can hit the posterior cortex. This will change the way I put my component in. So a rod hitting the anterior component would actually take my component into flexion, not put it into the right position that I want. And our implant can go into extension, causing anterior notching if it is hitting posterior. So I would want to a flexible rod. If I don't have it on table, then try to negotiate into the center. If I cannot, then the flexible rod helps me to give my perfect fit. This is a very small trick which I decided after seeing all my X-rays, lateral views. And this teaching actually came from navigation and robotics. When we started doing navigation, and now with robotics, we've realized I can just push my hand slightly down to get my flexion instead of just going in and pinning it. So I push my hand slightly down so I can pin my distal femur jig in flexion, and then I can go forward. So this is the lateral view of the same patient, and you can see we have been able to restore what we started off with. That is what you try to aim for. This X-ray we don't do routinely, only for the purpose of this talk. I did this case 4 days back and I've showed it here. Another patient, if you can see again that the calculation, this is what we look for, and we see this X-ray and we are very happy that we have achieved what we aim for. It is a good idea to do this because this is the same case which I had shown with the right side femur vara, left side not, and see what has happened. Sorry. So if you see here, we have been able to restore on the left side absolutely correct mechanical alignment. I have a 3 degree still left. It is 176 and 179 on the two sides. This is my standard teaching from my navigation, and this is what happens that if I put in a component, I want my component to go into flexion. So from 0 degree flexion, the moment I go to 1 degree flexion, and I can see what is happening. The yellow and the green lines are still not parallel. And this is when I put the component in 3 degrees of flexion, my component is actually now going to sit perfectly, cutting 8 millimeters on the medial side and 3 on the lateral. This is what, when I say I can use the anterior referencing jig as well, use the flexible rod and come down. Or now, yes, we have started doing the robotic system. So the robotic actually tells me, and this is where I have a component which is in 3 degrees of flexion, or another system saying a component in 4 degrees of flexion. So most of the femurs have to be flexed. You can use the distal femur cut jig to get that. Now coming to extension gaps. the distal femur and the proximal tibia cuts are parallel is my aim, and a rectangular gap with a balanced extension gap is what I aim for. If I have trapezoidal, then I first go ahead and do a soft tissue release. And if I know my cuts are fine and I can balance the cut, do not go in and start cutting again. First, try to balance it before you go in and cut. And so this is when the knee angle is 0 degrees relative to the mechanical axis with a balanced gap is what you aim for. The third part in a distal femoral cut is a joint line. Most of the distal femur implants are 9 mm thickness. So as much of bone you cut, the same bone you apply with a metal. You resect your bone with 9 mm. But in case of fixed flexion deformity, the standard teaching was you cut additional 2 mm bone. It will affect the extension gap, but what it will do is it will raise your joint line, which I don't want. Otherwise, it will lead to a patella baha. So I first would like to do a posterior release before I do any additional bone cuts. What happens is the mid flexion instability will come in if your posterior release has not done. The extension gap will now hinge on that very tight posterior capsule. The collaterals are not balanced in mid ranges. So it is a good idea to first do a posterior release before you do any kind of an additional cut on the distal femur side. And this is what you are trying to replace, that you cut, you replace with 9 mm and see what happens. A replaced 9 mm cut will give you a perfect fit of the joint line. But on the other hand, on the extreme right, if I take additional 2 mm, I have a patella baha and a raised joint line. So this is what you are trying to aim for. And the good idea is always look for the healthy bone. When you put your distal femur jig, look for the healthy bone so that the two pins should, otherwise you will cut more if you do it on the eroded side. So the take home message would be, failing to plan is planning to fail. Always understand that the distal femur cut is affecting your alignment and the joint line. It's not only the extension gap, it is helping you in putting your component at the right flex position. In the subsequent talks, they're going to talk of anterior and the posterior and other cuts. But what happens is when you are in between sizes, you try to tend to cut more. When you try to cut more, that is the time when this distal femur cut with a flexed component will actually help. You would not lead to actually downsizing. A poorly planned distal femur cut can be a source of unhappy knee replacement. Thank you so much.
Thank you, Dr. Ramnik. Nice presentation. I will request all the faculty to stick to time because we have shortage of time, and people from Australia and South Korea, they will be going into late night. So we have to finish also. So Dr. Ramnik, you can ask Dr. Asit.
Yeah, okay. Hi, Ramnik, Ashit Shah from Mumbai.
Hi.
So,
Hi, Ashit.
Whenever we make this distal femoral cut, is it your observation or any other faculty's observation that if you want to cut 9, you put your jig as per 9 and you take a cut, then you measure it, it is never 9. It is either 7 or 7.5. Okay, the lateral femoral condylina varus knee when you cut the distal femur. So at that stage, would you go and do +2 straight away, or you do the other steps, get the balance right, and then come back again for the cut in case if your extension gap is tight?
See, I never cut additional unless until push comes to a shove. I have done all my releases. So if I know I don't have an extension gap, but I see that the gap is still rectangular, then I would just go ahead and take my other cuts. What happens is the moment I take all my other cuts, inadvertently, it would be a 9 mm gap because of distal cut, your posterior release, osteophytes, everything gone. It actually just pops in right there in front. So an additional distal femur cut, I started off doing it, and I can tell you since 2014 or so, since I started doing navigations, I don't think I really go ahead and take a distal femur cut unless until it's a very gross FFD of 30-40 degrees, which I'm correcting.
Dr. Ramnik, a quick question. How do you do the posterior release when you have not done all the cuts with the tight flexion? So how to go ahead and do a good posterior release before you decide on this distal femoral cut? Revising.
See, so I would actually take my distal femur cut, my tibia cut is taken. Then I take a long gouge or a curved osteotome or a Lambert cut, whatever I have, and I try to knock off the osteophytes. I do not take those osteophytes, I just knock them off. I leave them there. Then I extend my knee, put in my calipers, and along with my calipers, then I just release the posterior capsule. It's there right in front, and I just release the posterior capsule. And that would be my first guide. Sometimes, otherwise, I will take all my 4 cuts. I will get my cuts there, and then I will again do my releases, remove all the osteophytes, and then so distal femur cut. Even after all my 4 cuts, I can go back and take again.
There is a
Ramnik, I
question.
think it's a wonderful presentation. One thing is that do you recheck in navigation? You always recheck, but when
Yeah, I
you
always
use
do.
conventional instrumentation, then also you can recheck that whether your cut is in the right valgus angle.
I put an extra medullary jig on top of that. If in doubt, the only thing I do is I put my spacer in the extension gap and pass my 2 rods towards the center of the hip.
Right.
And what I have actually seen is that most when you are there and with all the drapes and all, what I normally tell is that is what my anesthetist does. I give him a hammer. I tell him, put that hammer and make it stand on the top of the hip from the back. So where I know where that hammer is standing on my inside my drapes, and I know that my hip is and my rod is pointing towards that side.
There is a question.
Can I answer Ashit's question? Yeah, Ashit, I
Vijay,
agree with you that
please go ahead.
yeah, the distal femoral cut is very variable, and you never get 9. Sometimes it is 6, 7, etc. So you have to do the tibia cut next. Make sure the tibia is what exactly you want. You want whatever you plan for, because that's going to affect the flexion space as well. And then you got to do your extension space management with your spacer blocks and whatever is additional that you need. Provided, of course, there's no FFD, you need to take the rest of the femur. You need to do an extension space management before you proceed, and then you won't have any problems. The final step, you've got to do an extension space management after the tibial cut.
Yeah, correct.
There is a question from the audience. Does some femoral implant takes more bone posteromedially than others? Is there anything, any implant which takes more bone from the posteromedial side than others? Any femoral implant?
See, high flex knees which came in, they definitely were taking in more to additional 2 mm bone. So the Genesis, the high flex knee from Zimmer, Smear, they were all taking 2 mm more cut from the posteromedial side.
I think so. Smith and Nephew Genesis 2 would take the earlier
it's 9
design.
mm.
Genesis
it's
2.
9 mm.
No, but it will take more bone from the posterior lateral femoral condyle. So the earlier Smith and Nephew design, that's the Genesis 2. So in a Genesis 2 Smith and Nephew, the flexion gap will never be rectangular. It will be always be a trapezoid, and that much space will be filled up by additional.
Spacer blocks are trapezoidal as well. So
spacer blocks are
correct. And so the implant is also got more metal on the posterior lateral femoral condyle of Genesis 2 in Smith and Nephew design. I think so. They have the newer design, that is their Anthem. They have changed that.
Harish, would you like to share your screen?
Yeah, sure.
Can you just, Dr. Ramnik?
Yeah.
Can you just again tell about the femoral valgus measurement and the intramedullary measurement? Because as we know, there are only up to 7-degree valgus cuts are usually in all the companies. If it is more or if it is less, that means if it is less like 1-2 degree. So how do you do that, those cases?
So what I normally do is that these jigs have ratchets which interlock with each other. So it locks at 7, but I know that I want 9. So what I do is I just open the ratchet and slide it slightly more. That is what I normally do, is I open and slide it slightly more. And the distance between this is very small, 3, 5, 6, 7. So I am normally doing, so I just slide it slightly more. So I know I'm more than 7. That's what I normally do then.
Thank you, Dr. Ramnik.
Can I tell a word of caution here? See, most of the companies, that is J&J, Zimmer, or the Stryker, they have in single slot, they have multiple ratchets. So you can go from 3 to 9 degrees. However, Smith and Nephew has got different angle rod. So
yes,
if you are
those
doing
rods are there.
Yes. So if you are doing a case where your valgus angle can be different, please ask that person to provide you those rods. Otherwise, if you're just doing default 5 or 6 degree, he will just bring those two, and you need either 4 degree or 8 degree. You will be stuck intraoperatively.
Yes.
Yes.
Good remark. We'll move forward. Dr. Harish Bende will be presenting on the femoral cuts, different femoral cuts, what precautions we should take. Dr. Haris sir.
Thank you, Dr. Paddy. If you see, the femoral cuts are the probably most important cuts in the knee because they decide coronal alignment, they decide sagittal alignment, they decide rotational axis of the knee, they decide sizing of the knee joint. It also contributes the gap sizes, flexion, extension, gap balancing, and the joint line position in the knee. So the cuts in the femur technically decide entirely the way your knee is going to function. And depending on what logic you use, whether you want to go by mechanical axis or anatomical axis, or you want to go by kinematic axis, all these cuts can change drastically from one case to another. I don't want to make it very complex because it's a basic symposium, so we'll stick to mechanical axis in most of the cases. So basically, the distal femoral cut frontal alignment is basically to get a mechanical axis at 90 degree to the mechanical axis. So your cut has to be, which is a red line here, should be perpendicular to the yellow line. So you put an intramedullary rod, but you want to make that distal cut perpendicular to this mechanical axis. That is why you have to find out exactly how much is the angle between the two. That is called divergent angle between anatomical axis and the mechanical axis. And it could be usually between 5, 6, or 7 degrees based on the neck shaft angle. In a very varus knee, it could be divergent. You may end up putting 7 or 8. In a very valgus knee, these could be quite close to each other, and you could be putting maybe a valgus angle of 5 degree or even 4 degree. It has been described very well by the previous speaker, so I won't elaborate on that. But basically, you need to assess exactly what is the situation. More often than not, we have the knees which are having a bowed femur. And if the femur is bowed, what happens is usually your rod doesn't go to the end. It ends up only in the distal part of the femur. And then that usually goes into significant amount of varus position. So if you want to make an axis or distal cut based on this rod, which has not gone all the way up because of the bowing of the femur, you may end up taking the standard axis, and you may end up putting the knee into much more varus. So whenever you find a patient has got a bowing of the legs, the tibia or the femur, it is essential you should take a long film X-ray as described before. Otherwise, you'll end up going into varus. Second part is the flexion extension position. So in a coronal plane also, in a coronal plane, you can also make an error of putting the cut into excessive valgus. If your cut goes into excessive valgus because of your wrong valgus angle in a mechanical or in an instrumented knee, then you may get a knee which is excessive valgus, and this valgus deformity cannot be corrected by just releasing the soft tissues, because it is a mechanically created deformity because of the wrongly placed components. So is in a varus, and it can lead to excessive varus and laterally sloping joint line. These patients are not going to be very happy after the surgery, and they will be some of your unhappy patients. Then in a sagittal plane, if you can see, you need to have an angle which is right angle to the femoral axis. If you don't get a proper right angle to the femoral axis, then you may end up having a cut which is usually an extended cut. And this is very common in a patient which has got a very sclerotic hard knee, in a young patient or a patient with a severe osteoarthritis with a severe sclerosis. Now there the distal, as a cut goes distally, the distal end of the condyle is not cut very easily. Now it is not difficult to recognize that in a navigated knee, but if you are doing an instrumented knee, you are using a intramedullary jig. The simple way is, after you have taken the cut, just put the intramedullary rod again back into the medullary cavity and see whether you are at right angle to it by putting a flat scale on the distal cut surface. And you can, with a reasonable amount of accuracy, assess whether your cut is in less in extension. Because if you get a distal cut in less extension because you have cut less part of the distal femur, then you end up putting the knee into hyperextension. That is one. And the anterior cut will notch in the femur in the front. And this hyperextended patient, because the hyperextension is in a cuts and not in a ligaments, cannot be corrected by the soft tissue releases. And these people are not very happy because they cannot walk very well. They tend to get significant quadricep pain. The other end is you can put the cup excessively in a flexion deformity, and that can happen in a very osteoporotic patient. You end up cutting much more distally. And again, this can lead to the distal femur being in a more flexed position, the patellar flange of the femur will stand out from the anterior part, and these will interfere with the tracking of your patella. So it is very important that you make sure that distal femoral cut is not in flexion, because it will lead to permanent flexion deformity. And again, this flexion deformity cannot be corrected by doing any amount of posterior release in the knee. Now, anteroposterior cut decides the rotational axis, the sizing, and gap sizes. So there are very important things, and these all are actually interdependent. You can sacrifice getting one right to get another partly wrong. Now, for example, if you want to decide the rotation of the femoral component in a classical way, we have got multiple ways of deciding which is the rotation going to be of my femoral component. The commonest thing is the white side line, which is the depth of your femoral trochlea and height, highermost point of the intercondylar eminence, and then you can draw a straight line. Or you can have inter-epicondylar axis if you can identify epicondyles of the femur, or you can use a standard 3, 4, or 5 degree external rotated position compared to the posterior condylar line. But basically, you should try to mark all these three things and try to see that you are somewhere in between the two, because each of these things is not accurate in all the conditions. They are right normally in anywhere between 75 to 90% cases based on the femoral geometry of your patient. So you should try to see how you are. And lastly, the component balancing, the rotational alignment and AP cut, which are eventually done based on what you accept, also has to match with the flexion gap balancing. So sometimes you may also use the tibial cut surface as a reference to decide how your AP femoral cut is going to be, especially if you are using a technique called gap balancing technique, where you first balance your extension gap and then you try to get a flexion gap which is equal by balancing and rotating your femur with respect to the upper end of the tibia under a stretched position. So the AP cut basically is quite variable, and that cut basically decide exactly how the femoral is going to be rotated. It is also going to decide what is going to be your axis of the femur. So this is the classical way of doing a femoral component rotation using either a white side line or inter-epicondylar axis, or using a fixed external rotation based on a posterior condylar of the femur. Now, it was simple till now, till people started talking about kinematic axis, and this has become more complex because now these are the axes which are not easily recognizable on a bony anatomy, because these are axes based on the kinematics of the knee, how the patella moves around the proximal part of the femur, how the tibia rotates around the distal and a posterior part of the femur. So accordingly, you can get a tibial and a femoral axis, and you are supposed to align your knee with respect to these axes. Obviously, this is not very easy to do without navigation or without robotic surgery. Manually, it is there are ways of doing it by taking a fixed amount of bones from all the surface of the femur, and you presume that they will become kinematically aligned. So these are more complex things. My suggestion to people who begin the knee replacement surgery in their first 100, 200, or 300 cases, they should not worry about kinematic axis. They should go still by a standard mechanical axis therapy and go by a standard white side line or an inter-epicondylar axis. Then we talk about gaps and sizing of the femoral component. Now you can see that this is a lateral view of the femoral bone, and the arrow shows where is the posterior condyle is. Now, unfortunately, we do not have the femur in infinite sizes. In any company, you get femur which are maybe 5, 6, or 7 sizes. And obviously, the AP dimensions of these femur are increasing in a discrete number. They will not be variable number. So the AP dimension of this femur, for example, if it is 53 millimeter, you may have a component which may be 50 millimeter and upper one is 55 millimeter in AP dimension. So that means you have to choose between either a slightly smaller component or a slightly bigger component, because you cannot have the one which you really want, which fits the AP dimension of the femur in your patient's case. So you may end up putting component which is little smaller, which will reduce your posterior gap, which will increase your posterior gap. Then again, if that component is placed flush with the distal cortex by cutting the exact amount of bone which you want to replace, you will create a good joint line. If you put a bigger component like this, then eventually what will happen is you'll be filling the flexion gap, you'll be cutting less, putting more metal, and then the gap will change. So basically, femoral AP cuts also is going to decide the size of your component and the gaps which you leave in your flexion and extension position between the tibia and femur. So when you are doing these AP cuts, it is very important to balance all these three things together. The third thing is your joint line. And I'll come to that in the next way. Now, this AP movement of the position of a component, one way we can help is using the anterior leeway. Now, it is not always necessary that your anterior cut has to be flush with the anterior cortex. You have normally a thickness of about 6 to 8 millimeter of anterior condyle. And there you have at least a leeway of 2 or 3 millimeter where a component can be shifted slightly anterior so that your flexion gap opens up a bit. And this anterior leeway can be used by a surgeon, even in a manual technique where you can balance the flexion gap to the extension gap by varying without changing the size of a component. So surgeon has a way to find out what is the best gap and what is the best flexion gap you can create by either upsizing or downsizing the component. And then this component can be either put slightly anteriorly or just flush with the anterior cortex using the anterior leeway which the patient has in most, which the surgeon has in most of the cases. Then you come to the distal cut where you can put the cut flush with the distal cortex that retain the joint line. You want to get a little extra cut and then put a implant, you change the joint line. So this also changes the position of a component, position of the extension gap and a position of a joint line with respect to which the patella is going to track. So basically, if you can see, these components can have the cuts which you take on a femoral have a significant influence on multiple factors. And these AP cuts has to be taken into consideration, considering all these factors together. So do we want to upsize? Do we want to get the component little proximal or a distal? Do we want to get the component little anterior or posterior? And then whether you want to also rotate the component little more or little less to balance the flexion gap. So all these things is very important, but it is a complex mechanism which a surgeon has to understand when he does the knee replacement surgery. So basically, if you can look in nutshell, femoral cuts decide how your TKR is going to function. So it is very important that you think well, think about all the aspects which will change by the changing of one part of your tibial femoral cut. Plan in advance exactly what you want to do. Do you want to have more flexion gap or less flexion gap? Are you faced with flexion extension inequality? All that thing has to be planned in advance. And then once the plan is decided, execute it perfectly, because only then you can get a balanced, perfectly balanced knee. So thank you very much.
Thank you, Dr. Harris. I will request everyone to please stick to time because we have already we are late. So Dr. Harris, it was a nice presentation. I mean, all the young surgeon will want to know what is anterior referencing and what is posterior referencing, and with that, how we measure. Can we change the anterior referencing system to a posterior referencing in the same system, and how does it work?
It's a good question. It is a little complex and I couldn't include that in a small talk. But basically, when you want to make a cut on a femur, you have to use a cut with respect to either an anterior cortex and put that as a reference point. So when you increase the size of a component, the increase in size goes posteriorly. So using the anterior referencing, the anterior cut goes flush with the anterior cortex, and upsizing the knee will cut less bone posteriorly and it will fill the flexion gap. On the other hand, this is used normally when you want to make the extension gap first and then put the component to balance the flexion gap. In the other hand, when you use a posterior referencing, we use a posterior referencing point from the posterior condyle and cut a fixed amount from the posterior condyle. So basically, then you are going to create a same flexion gap whether you use a small size or a big size component. If you use a bigger component, the component goes anteriorly, it crowds more in the anterior part. So when you want to get a posterior referencing, you are trying to get a fixed flexion gap, but then you can upsize, you cannot downsize, because with the downsizing part, if you use the posterior referencing, you may end up notching the anterior part of the cortex. So usually the safer and easier way is to do anterior referencing, and most of the systems about 70-80% of the surgeons, they normally use anti-referencing system because that is more flexible and that is more permeable.
Whenever there is posterocondylar defect, so when we go for measuring the size of the femur, what precautions we should take?
Now, if there is a posterocondylar defect, which can happen typically in a very valgus knee, there may be deficiency of the distal and posterior part of the posterior condyle, in which case you have to use the medial condyle as a referencing point, and usually use that to measure the actual size of a component. But what is more important is not a sizing of a femur with respect to the normal anatomy. Use that size to balance the flexion gap with what you achieved in extension. So normal logic we use is we create an extension gap first by taking distal femoral cut according to the anatomical landmarks, taking fixed amount of bone from the distal femur, take upper tibial cut, whatever you want to take a minimum insert size, balance that gap. So you create a gap which is maybe 18-20 millimeter. And then you want to create the same gap in flexion. Now already one cut, the tibial cut is done because you have taken the tibial cut. So now you have to make a jugglery of changing the femoral size, changing the femoral position, and to some extent changing the femoral rotation. So all these three things are done in this second stage to balance the gap. So many times the actual dimension of femoral size is a fourth priority. We are not much worried about the actual dimension, whether we are going to get it slightly more or slightly less. What we want to know is whether we can get an extremely well balanced flexion gap by doing some jugglery with these three parameters: the AP positioning, the rotation of the component, and a sizing of a component. And that is done by your AP cut.
Okay. I will request Dr. Vikas to put up this slide. Meanwhile, one more question is there asked by Dr. Arun Gupta. He's asking, Indian knees are broader in AP dimensions vis-a-vis mediolateral dimensions. So for that, any special precautions we need to take doing our different femoral cuts?
The aspect ratio of different knees are quite variable. For example, the aspect ratio, the medial ML to AP dimension of Zimmer knee was slightly broader. And that's why probably they have to come up with a narrower knee, which they labeled as a gender knee, which was narrower mediolaterally for the same size. And many times people who use gender knee have used gender knee for many time of male patient also. It is not that it is used for a female patient, although it was the way it was marketed. So in Indian knee, well, I do not want to make a specific mention in our this thing, but there are some knees which are based on the Indian dimension and Indian geometry. And these knees which are based on the Indian geometry, like Merrill, they have a much better mediolateral dimension which can fit the Indian population very well. The older knee were done as a copy of Haumedica knee or copy of Zimmer knee. And those knees were not very good because they used to have very large mediolateral dimension. And they would cause a big overhang when you used to get a proper AP size.
Dr. Rajiv, any question from the other platforms?
No, I don't think now. It's a wonderfully presented talk, Harish. Thank you so much. We just move on to Dr. Vikash Kapoor.
Yeah.
Dr. Vikas, please.
Yeah. So my dissertation today is tibial base plate placement and with relation to size and rotation. This is not moving. Okay.
Yeah.
Yeah. So basically, we go by various studies which have been discussed in last 10 years. It is a matter of interest in last 10 years, in decade, that, and these are the studies which I quote. So one of them was in the journal Knee in 2015, oversizing the tibial components in TKAs, incidences, consequences, and risk factors. And they showed that it was significantly greater or more frequent in females, as we know that in most of our population also the female size is very different and small, and tend to kind of we get more overhang or soft bones in females. Patients oversized in AP dimension had lower postoperative pain scores, and patients with mediolateral oversizing had decreased flexion after one year after surgery. AP oversizing was observed more frequently in patients with asymmetrical tibial plateaus, which is a phenomena again which has come up in last 15-20 years as we recognize through navigation and other techniques. Mediolateral oversizing was observed more frequently in patients with small tibias. So the most important issue in this sizing is mediolateral translation. So the goal, as you can see in this photograph, is to provide maximum coverage when possible, have component extend to the cortical margins, so that in bones which are not which are very soft, kind of get adequate cortical support. Laterally dislocated soft tissues, the practical point in while doing surgery is that the laterally dislocated soft tissues tend to push the trial component medially. So you are not able to lateralize your component, and that needs to be resolved with adequate retraction and, as you can see, with proper careful planning. Now, the overhang issue, the medial overhang is usually avoided, but literature shows that overhang itself doesn't really have too much pain. There are too many other issues also. And slight lateral translation actually helps to centralize the patellar tracking, which has been shown in various studies. And too much external rotation of tibia components, especially the anatomic ones, which are coming nowadays, can cause popliteus tendon impingement and can be a constant source of irritation. And femoral overhang has been shown to be a bigger problem than a tibial overhang in most of the studies. As you can see, this study demonstrates the incidence of oversized tibial plateau components is surprisingly high. So even they took a cohort of a lot of knees and retrospectively analyzed it, and they realized that most of almost 30-40% of these knees show tibial overhang. So it's not, and although they were not showing too bad pain scores, but the risk of oversizing could be predicted as it occurs predominantly in patients with asymmetric proximal tibia. So we need to understand, once we cut the tibia while operating, we don't have CT scans in all patients, but once we cut the tibia while operating, we will be able to kind of see what kind of tibial anatomy we are going to expect and accordingly size the tibia. So the effect of tibial component sizing on patient-reported outcomes here, on the contrary, is actually showing something different. What it showed was that the overhang or undersizing is not detrimental to outcome. So this is one of the outlier studies which is there, which shows that overhang is not actually a big contributing factor in bad knee scores. The other issue is the AP translation of the tibial component. So while putting the tibial component, the main goal is to provide the maximum coverage. If it is a symmetric component and it is sized to fit the AP length on the medial plateau, actually medial plateau is a larger plateau. So if you have a medial plateau and AP, it is fitting on that, it will either overhang posteriorly on the lateral plateau, or it will tend to internally rotate because the medial plateau AP distance is higher. The solution is to compromise in the AP coverage and then allow overhang or internal rotation. An appropriately sized component is then placed as posteriorly as possible, because that will, as you see in this photograph, for every millimeter of posterior placement of component rather than rotation of component, 2 to 2.5% of decreased patellofemoral pressure is there. So if you push back the component and centralize it more on by 4 millimeters, you will have approximately 10% less patellofemoral joint reaction forces. That would probably lead to a better, happier knee. Tibial component coverage affects the tibial bone resorptions, and patient-reported outcomes measure for the patient. In this case, as you've seen, if you have an appropriate sized tibial component during TK, it is extremely important, because it would have, if you are placing a smaller component, it would have a sinking effect. If you have a larger component, it would have a overhang effect. But if you have a good cortical support, there are very low chances that you would have much of a problem in these patients. Also, in one of these biomedical studies, it has been shown that although there is a substantial amount of bone resorption and the lateral and medial region of interest, where the plate is seated in the bones, but actually it has not much of effect on the outcomes of various studies. So we should be able to have a peace of mind that even if you are seeing the resorption, but you don't have much problem, the patient is fine. Tibial base plate for total knee arthroplasty, these are newer issues regarding base plate, symmetric or asymmetric, what to put and when to put. Here you can see that the posterior referencing line has become kind of sacrosanct and a good marker today, posterior condylar axis of the tibia, and then a 90-degree from there to the medial edge of the patellar tendon forms actually the landmark for putting ideal rotation of the tibial base plate, or in external rotation. You cannot err on internal rotation. So component overhang has been known to cause soft tissue irritation, overstuffing of joint, etc. So reducing the excessive overhang may entail compromise of alignment or size of the component, potentially leading to component subsidence and loosening, which we have discussed. In this study, the uncovered area was greater in the group where asymmetric tibial base plate was applied. Again, this point is coming up. Maximum coverage is required for uniform load transfer. Insufficient tibial coverage may occur unintentionally, even if close attention is paid to compatibility of the femoral cut and component. An error made with one of the components can lead to effective outcomes of TKA. So deviation from posterior condylar axis of tibia is greater in asymmetric group usually. And this study also showed that small movements made to increase the coverage with asymmetric tibial component can result in rotational errors. So rotation, there are two sacrosanct points: avoid internal rotation of tibial component at any cost. And the second one is too much external rotation of tibial component can cause popliteal tendinitis or tendon irritation. Also, if you keep the internal rotation in abeyance and do a bit of external rotation, you actually tend to decrease the Q angle and therefore have a better patellar tracking. Another biomedical research has shown that malposition of tibial component mainly affects the ligament tensions, but also influences the tibiofemoral kinematics. Medial malpositioning of tibial base plate has strongest influence on these parameters, and potential clinical consequences are post-op pain, reduced range of motion, etc. There are 6 designs which have been compared in this study. The design A is the persona knee, design B, which is an anatomical knee, design B is the NK2 knee, which is asymmetrical knee, tibial plate, and all other designs C, D, E, and F are various other knees, including the deploy, which has a symmetric base plate. And as you can see, as you external rotate, the green line and the red line, they are closest in the design A, which is anatomic knee. So technically, the amount of external rotation does not really change the alignment of the tibial component too much. So it helps in giving you a better fit. In this study, it also shows that in symmetrical base plates, as you rotate, the amount of rotation and component sizing, once the component size becomes less, like size 2 is placed instead of size 3 in order to accommodate the rotation of the knee, external rotation of the knee, there is a huge amount of uncoverage of the tibia. So the coverage of tibia does not get affected in a design which is anatomic if you reduce by one size. But as you reduce in other sort of knees which are symmetric, they will markedly reduce the size and coverage of tibia. Here, this line is very interesting, and this is called Akagi line. Basically, it is a straight line drawn from the perpendicular axis, perpendicular to the posterior condylar axis. It is from the midpoint of the PCL and is supposed to pass just lateral to the medial part of the, or touch the medial part of the patellar tendon. But actually, it is not the 1/3 of the tibial tubercle. So this line has been described as one of the ways to actually put the tibial component in relation to the PCL, which is a very interesting thought. Actually, these are my patients which I'm going to show. Here you see the PCL. When I put my components in these cases, it usually comes to approximately 1/3 of the PCL from the medial lateral side. So 2/3 of the PCL is on the medial side and 1/3 is on the lateral side. and the horizontal line is the line which is parallel to the transepicondylar axis and is the largest line on the tibia and mediolaterally. So technically, this is the line which I have found most of these knees, they tend to rotate. And here you can see one knee in which I think this is next gen, this size being used. No, this is a standard Depot prosthesis. And you can see the overhand. This is if I try to cover the tibia on the lateral side. The next knee, which you can see here, a Smith & Nephew type of prosthesis being used. And here you see it is more of slightly anatomical, and you can see better coverage on the medial side, although there is some amount of overhang which of extra bone which has to be trimmed. But here again, the PCL is being referenced, and anteriorly it is being externally rotated from the mid-third of the tibial tuberosity. This is a persona knee where the posterior coverage is being seen after taking the external referencing as we take it. The posterior reference, posteriorly, this knee is not going out when you cover the lateral and try to match the posterior condylar axis. So this probably shows that asymmetric tibia is actually going forward if you have a better, it would have a better fit and finish. Here again, next gen knee, you can see similar landmarks being used, and in next gen again you can see the end of the medial edge of the posterior condyle of tibia is getting slightly more exposed as we are trying to rotate and put the knee in a proper external rotation. So technically, take-home message is the tibial size and rotation. Do not oversize. Try to do an edge match. If it does err, if you do an error, err on lateral side minimally for overhang. There is no scope for internal rotation under any circumstances. Err on external rotation always if you actually have a problem. And posterolateral overhang is best avoided because that is a very unhappy knee. Thank you very much.
Thank you, Dr. Vikas. It was a nice presentation. There is a question from Dr. Mirinal. He's asking how accurate is the range of motion technique as compared to the external rotation axis technique. So how accurate is the range of motion technique marked in extension, considering that it changes in flexion and extension, preparing the tibia and trying to achieve the optimal tibial coverage. So when we go with the axis and external rotation technique, the flexion extension mark, when you had a mark, that changes. So which one to follow?
See, I think it is the coverage technique which is easier and better to follow, because eventually the problem comes in a rotate, and the solution to a better solution to this is an RP knee probably. To some extent, you can have some amount of rotational correction also internally if you have a malalignment. But basically, what I find more logical is while doing this flexion extension technique, your implant tends to move sometimes medially or laterally when you are doing the flexion extension because it's not fixed. And then you tend to, you can have an idea, but you cannot really call it a sacrosanct technique. It's better to see, visualize, look at your overhang, see what compromises you can make to get the best balance of the tibial positioning of the tray.
Can I make a comment?
Yeah, yes, sir.
Devabrat?
Yes,
Yes,
Hari.
If the rotation of the tibial component also depends on whether you are going to use CR knee or a PS knee. If you are going to use a PS knee, you've got a box and a cam design. It is quite mandatory that your box and cam are aligned to each other very well. That is the reason it is necessary that these cases, when you are using PS knee, you have to rotate your tibia with respect to what your rotation your femur has. Otherwise, if you just get your tibial rotation with respect to the tibial cut and coverage technique, then you may have edge loading of that. So if you are going to use PS knee, you have to go by flexion extension position and see in what rotation of tibia the cam of the tibial insert will not impinge along the box of the femur.
Actually,
but if you are using a CR knee, it wouldn't make a big difference because there is no box and a cam to get engaged into each other. And then maybe you can use a tibial coverage technique to decide the tibial rotation, because your femur can have some element of a rotational thing. So does it happen when you're using a rotating platform design, when you don't have to worry about, you just get a best coverage of the tibial component on the tibial bone, and the little rotation malalignment will not make a big difference because the rotating platform design will adjust for that.
Yeah, I think
Hey,
that is a
can I-
very strong and good assessment, because I have a very strong feeling that rotating platform was more of a better solution to this problem rather than high flexion or any other problem.
Very
I
right.
think,
Can I,
quick-
can I,
quick
can I
response.
come in, Rajiv? Yeah.
Can we ask here Dr. Briard?
Dr. Brad, please give your opinion on this tibial base plate placement according to the flexion extension mechanism or according to the axis of rotation.
Especially mobile bearing, because Dr. Briard has been using the mobile bearing for the longest period of time. Is it there?
Professor Brad?
Vijay, in the meantime, maybe
He's muted.
can we have
So
your...
Vijay,
So it's been well published that in a properly done femur, the tibial rotation can be anywhere between the medial edge of the tibial tuberosity to the junction of the medial 1/3 and the lateral 2/3. That's the area that you can play with. If you go beyond that age zone, then it becomes incompatible with the femur. Whether you use PS or CR doesn't matter. So within that zone, you can have a free-floating technique to change that a little bit. You can fine-tune it, or you want to use other things. But that's the zone that you want to be in. And depending on the patient anatomy, coverage, free-floating technique, whatever you want, you can play around within that zone. But it's important to be within that zone of middle border of the tibial tuberosity to the junction of the middle 1/3 and the lateral 2/3. And that's for the beginners. You have to be in that zone, but you can fine-tune that zone depending on whatever you want to do.
Yes, very rightly said, Vijay and Harish. If it is a mal-rotated tibia, then the biggest problem is the wear of the post and even the breakage of the post, which is possible.
I think Dr.
Professor
Brad
Han-
is wanting to say something, sir, and he's
Yes,
muted.
Abhay can.
Yes, Abhay, please.
Dr. Brad is trying to say something, but he's muted. Someone will
Oh.
have to message him.
Yeah. Dr. Briard, can you please unmute yourself? Okay, in the meantime, maybe the next speaker
Vijay,
can...
Vijay, you can just put on your slides in the meantime. Dr. Vijay.
Yeah, I'm doing that.
So if Dr. Brad is not there, Professor Han, what is your experience? Professor Han, are you listening?
Maybe we can take up the question in
Yeah,
the
let
next...
one, you can take that. So we'll go to Dr. Vijay Bose. So we'll be speaking on the sequential medial release. That is the management of varus deformity. He will be speaking some new techniques. Over to Vijay, please.
Thanks, Deba and Rajiv. I'm not talking on new techniques, but the focus on the seminar is to see how to avoid unhappy knees. So my focus would be on that. So conventional technique in 1984 was the so-called first TKR ever done by Insal. Now what we call as modern total condylar designs. And of course, Insal was, always conventional teaching of Insal Ranawat is that once you remove the osteophyte, and the next structure that you have to do is your superficial MCL. That has been the conventional teachings and Insal's diagrams of how we do the anterior part, posterior part. That's what we have done over the last 50 years. And that has been the conventional technique for managing varus knee. However, things have changed in recent times. There's no question about that. And this is the editorial by Faraz Haddad in 2020 in the Bone and Joint Journal. And I want you to look at it very carefully. Respecting the soft tissue envelope while achieving mechanically sound prosthetic alignment is a promising way of improving out following total knee arthroplasty. Functional alignment is proposed. So the post-op alignment is also a reason for why they have a poor satisfaction. 20% are unhappy. So I think more and more people are trying to address that issue, and I think we must look at that. Now, the era of complete mechanical alignment is over. I think all of us should accept that. How much you can deviate from a strict mechanical axis may be debatable in 2022, but for every case, to achieve a strict neutral mechanical alignment, that concept is dead. Thanks to Pegnano and Dan Berry, they have published excellent thing, and not many authors as well. This was the first paper which was published in 2010, and they had a 15-year survival rate of knees which are not in full mechanical alignment. And the follow-up paper came in 2018, 20 years. with all the knees that were not in full alignment, but still did very well. So the era of for all patients going for a full mechanical alignment, that era is completely over. The current TKR tendon, as far as I as said in the editorial, is to maintain hemostasis in TKR as in UKR. UKR patients are more happy with their knees. So basically, what you want to do is a soft tissue friendly TKR or a functional alignment. So this is how you do in a UKR. You'll have a one leg standing view, you have valgus stress view. The post-op must look like a valgus stress view. So they not release any ligaments. So similarly, if you want to do a soft tissue friendly TKR, this is how it must look. The one leg standing, the valgus stress, and the post-op X-ray must look like a valgus stress. That's exactly what we're trying to achieve. Now, if you look at the surgical anatomy of superficial MCL, superficial MCL has attachments far away from the joint, way away from the joint. Now, if you look at pathology, we have to differentiate contractures which are inside out and outside in. Now, if you look at osteoarthritis, it's an inside out pathology. The pathology starts in the joint and goes outward. Whereas if you talk about something like polio, which is an extraocular contracture, structures far away from the joint will get involved. So when you have an arthritic pathology, it stands to reason that only structures that are close to the joint will get involved in the arthritic process. The superficial is much away, like the iliac psoas. It will never get involved unless there is a subluxation or a dislocation. The superficial MCL will not be involved in the contracture. And that's where probably we were all over-releasing knees, and that led to a lot of dissatisfaction. So superficial MCL is a structure much away from the joint, and it will not involve in an inside-out pathology typical of a osteoarthritic or a rheumatoid knee. And that's very thing of an arthritic knee. So superficial MCL is not the primary pathological structure in varus knee. Many of us still think that the superficial MCL is the primary pathological structure. It is not. So are we climbing the wrong tree by addressing superficial MCL? A lot of authors have published an important paper by Arun Mullaji saying the same thing, that superficial MCL is really not the pathological structure in varus knees, unless of course you'll get involved when you have a sublux or a dislocated. So they seem to be climbing the wrong tree by addressing the superficial MCL. So then why, if that's not the pathological structure, why still surgeons release the superficial MCL? Well, there are some intrinsic medial side causes, wrong positioning of your components. You've done your component positioning wrong, and therefore you get a pseudo imbalance. You're trying to correct by releasing it. You are chasing the mechanical neutral axis rigidly in all patients. Everyone you're chasing the mechanical axis, and that leads to unnecessary releases. And non-removal of remodeled bone gives you, especially in the tibia, tenting of superficial MCL is probably the most important cause. And you're using implants and not matched, as Harish said earlier, not matched for a local population. It lead to tenting of the superficial MCL. These are the reasons why surgeons still keep releasing superficial MCL. However, there are indications in which superficial MCL may be required. And what are these? These are extraocular varus in tibia. You need an intraocular correction. So whenever you have extraocular varus, you need to correct it. And therefore, you'll be releasing the superficial MCL. Distal femoral varus remodeling, again, is the extraocular deformity. You'll have intraocular correction, you'll be releasing the superficial MCL. Laxity, very, very common in our population, lateral laxity. And you've got to release the superficial MCL to equalize the lateral structures. And then the presence of gross joint line obliquity. So these are the big four causes, extrinsic causes, and big four intrinsic causes. So the real message is that you must not be releasing for intrinsic causes, and you must be releasing the superficial MCL only for extrinsic causes. Now, extrinsic causes you must find out pre-op, not per-op, and say, okay, my knee is not balanced, I'm going to release the superficial MCL. Must be picked up pre-op. So how do you pick up? By well done X-rays. You do a one leg standing X-ray, which will give you the lateral laxity, as in this case. The extraocular varus, a scanogram will give you the extraocular varus, the tibia or the femur. Or if you have a joint leg, a valgus stress X-ray will give you a very oblique joint line. So these are the causes, the extraocular causes, which you have to release to equalize the spaces. Another important thing is the gait. So if you see the gait, they'll have a waddling gait. Or if you see adductor thrust, then you know that the lateral structures are lax. And you've got to equalize the middle side by releasing superficial MCL by whichever technique to equalize. So you must know whether you're going to release or not pre-op, not per-op. And per-op, if you find tightness, that means your component positioning must be revisited. It's not the reason why your technique is wrong, and it is not the patient whose thing is tight. So if the pathological structure of the varus knee is not the superficial MCL, what is it? This is the remodeled bone on the tibia. So whenever you have sclerosis on the tibia, in both the AP and the lateral view, that means the remodeled bone, and that's what you must release. It's not the superficial MCL, but the remodeled bone. So you got to put a correctly sized tibia, not undersized tibia, and remove the extra remodeled bone, and then you'll find that you'll never need any release for any causes. Sclerosis on the X-ray is a good sign to know that you've got to do some kind of subtraction you have to do. Tibial reduction osteotomy was described by Ranawat and Balaji. And typically people think that you have to lateralize and undersize the tibia for reduction osteotomy. You don't have to do that. You have to get the correct size component. You keep it anatomical, but you may need asymmetrical tray or anatomical tray. And whatever is excess bone is the pathological structure. And once you remove that, you will not have to release in any intrinsic cause of for a varus knee. So whenever you have a sclerosed bone like this, in the post-op X-ray, you must see that sign that you have done a good reduction osteotomy. Then you know that there is no superficial MCL that is required. And multiple examples of this process, the reduction, the subtraction of the remodeled bone, and everything falls into place. But you must see this in the post-op X-rays. All these X-rays must. Now, when you have extrinsic causes, we told the 4 important extrinsic causes. When you can have your own method of releasing whatever you are comfortable with. But this is what we do when we want to release the superficial MCL. When we know pre-op, we need to release the 4 extrinsic causes by good X-rays and assessing the gait pattern. It is not a per-op finding. So this is the case. You can see the lateral side is lax flexion, medial side is tight. Extrinsic cause, patient had lateral laxity. So I'm putting now the trial spacer inside like that. And you can see that very clearly the lateral space is lax. Medial is tight, the patient has lateral laxity, very common in our population. So now we take once you have the trial, then we take 16 gauge spinal needle and then we pie crust the superficial MCL. So it will be like tenting on the medial side. So we take a 16 gauge spinal needle, and as you can see, as you keep pie crusting it, this will snap back into place. Very nicely snap back into place. So this is for extrinsic causes. Now you can find that in the extension, you find I'm not able to extend the knee now because the lateral space is lax, middle is tight. So you keep it in mid flexion as well as in extension, and you do the same maneuver. Now when you have the trial components in place, there's no risk of over release. You can safely release the superficial MCL in this technique. There is no, because there is a check on the lateral side. There is no risk of over release. As I keep doing pie crusting, I'll be able to get more and more extension till the space equalizes and get a solid, rigid, nice knee. You can see that. And then as you do more and more pie crusting, you keep manipulating the knee into extension, and then you'll find that you'll get full extension as the superficial MCL sort of elongates. Then you get full extension. So you got a very excellent balance, very safe technique to do, but you can do whatever technique. But all extrinsic causes will need release. There are other causes is posteromedial tightness. Whenever you have posteromedial tightness, you must have subluxation of the tibia. Then you will need. And typically what we do is a typical posteromedial semi-membranous release. We do like that. Dr. Ashok Rajagopal has described a posterolateral tether. And whenever you recognize this on the X-ray, it's important to do a posterolateral release in a varus knee. These are all very rare conditions, maybe less than 2% of the cases. But when you have it, you have to do those additional as well. I will not talk about the distal femoral angle, already talked very much. But basically, don't chase mechanical access in all patients. Try to give a functional alignment in patients. So the take-home message today is strict mechanical neutral alignment is not required in all cases. Soft tissue friendly TKR is functional alignment seems to reduce patient dissatisfaction with TKR. Superficial MCL is not the primary pathological structure in varus knee. Remodeled medial bone is the primary pathological entity and must be removed. Superficial MCL release required only for extrinsic causes of varus deformity and not for intrinsic. So since 2017, we have never done a superficial MCL release for any case in which there was no extrinsic cause. We have never done for an intrinsic cause. We have never done that. Pie crusting of superficial MCL using a 16 gauge spinal needle. The trials in place so that you don't have any over release. It's an excellent way to achieve in any extrinsic cause without a risk of over release. So thank you for your attention. Thanks again for the opportunity, Deba and Sanjeev.
Thank you, Vijay. Thank you. A nice self-explanatory talk. So one doubt is there, when you do pie crusting, which one you prefer, the femoral attachment, the midline, or the tibial attachment? Which side you prefer?
No. It's you do it sort of near the joint line, and different ranges of flexion. You'll find different portions of the superficial MCL getting taut, and they will selectively pick up those fibers that are taut, and that's what you must release. So flexion will be different fibers, in mid flexion will be different fibers, in full flexion will be different fibers. And so with this technique, with the trials in place, you release only as much necessary, and then there is never a risk of over release.
So is there a chance of any MCL tear or anything you have?
This is a very safe. The trials must, if you suppose you use a laminar spreader, for example, it's uncontrolled force. You don't know what you are distracting. You don't know how much you're distracting, and you do release. Then there's a chance that MCL may be disturbed. But here, there's no chance of inadvertent MCL damage. It just doesn't occur.
Professor Brad, do you do pie crusting of MCL in your practice for severe varus knee if you find after implant position?
Well, first, I ask a question to the patient. How was she walking when she was young or when he was young? So if he was walking with a severe varus, well, you can imagine that he has a extra-articular deformity. All the soccer players have a tibia varum. So if they were known to have bow legs, I think they have this deformity. And also, when I need to do a release of the compartment, I always start with the posterior capsule.
Okay. So how commonly you do a pie crusting?
Okay, I do pie crusting if there is only if I need 3 millimeters.
Okay.
And then if it's not enough, then I release all my medial side. Well, I start posteriorly, and then I do it in they are all together, and I release from posterior to anterior, and I never go to anterior.
Professor,
And I check, I look in flexion, and I check that my tibial cut is parallel to the transepicondylar line. I never go further.
okay. Professor Han, you can keep your presentation on.
Yes.
Professor.
Okay.
No, Dr. Brad will be presenting next. Sorry, Dr. Brad will be presenting. You can put up here. Before that, Dr. Vijay, how sequentially you go? Means how much initially medial release you will do, up to which level you will do when you see say a 30-degree varus knee in a normal patient.
That's what I'm saying now. So examination under anesthesia, examination of the patient in the clinic is not valid because you're still not taken the deep MCL off. So once you expose the knee, that's when you must do your examination on anesthesia. And you find that most patients would be correcting to neutral if they don't have any extrinsic causes. Super MCL itself is not a tight unless it is sublux or a dislocated knee. So we will, whenever we need release, we find the cause pre-op, and then we will pie crust the superciliary MCL to get to elongate the superciliary MCL same to the lateral structures. So this identifying the structures and releasing it, all that is only in a sublux or a dislocated knee. It doesn't occur in a standard varus knee. That's not the pathoanatomy of the varus knee. That's what I'm trying to say.
The point well taken. We'll move forward. Professor Brad, you can present on the aligning the valgus knee. Professor Brad, please.
So I've been asked to speak about genu-valgum, and next. Okay. Does it work with me? Oh, no. Okay, so we have to look at the component of the deformity. Is it inside the joint? You have the wear. Then the collateral frame, I think it's very important. In the concavity, is there any retraction? And in the convexity, is there any stretching? And we will see what it means. And then do we have extra-articular deformity? And is the deformity femoral or tibial? Next. So, next. Okay, so we classify the genu-valgum into 3 types, and they are completely different. So it's a very important. It's not just a genu-valgum. It's a genu-valgum type 1, type 2, type 3. So type 1, you have no medial laxity. And then you have extra-articular deformity, and where you can have lateral contraction, bone loss. So that's the most frequent one. And then you have type 2 with medial laxity. It's where you have complications most of the time, so we must be very careful. And type 3, it's a genivalgum due to extra-articular tibial deformity, and we will see it's totally different. Next. So we look at the shape of the femur and the tibia when they were and so we found that most of the time we have a femur valgum, and sometimes we have tibia valgum, but femur valgum is far less, is very frequent. Next. So when we were superimposing the two condyles, well, they perfectly superimposed, and they have the same size, maybe 2 millimeters smaller, the lateral condyle. So, well, in genivalgum, the lateral condyle is more proximal, and so you see here, it's really the same size. Next. So in fixed genivalgum type 1, we have most of the time normotibia, femur valgum, which is due to a curvature in the metaphyseal area. It's about here. So when we look at the soft tissue, contraction of the soft tissue, well, it's a contraction. It's really a contraction. It's due to inflammatory process adjacent to the wound joint surface. But that's for rheumatoid disease. Most of the time, the soft tissues are normal, but they are short because we want to bring the knee to neutral. Next. So let's understand the soft tissue. So I think the posterior is very important. So we have the arcuate complex, which is mixed with the posterior capsule. And then we have the lateral structures. We have the popliteal fibular complex. Here we have this ligament, and we have the LCL. And then we have next we have the iliotibial band, which is a very important stabilizer. And I encourage you to read a Whiteside paper. Next. So it's very amusing, you know. It has been written by Dick Scott that lateral tightness and medial laxity are usually not a problem in flexion. That means that the collateral ligaments are normal in flexion, and because it's a coronal deformity. Next. So when we want to correct femoral extra-articular deformity in the usual type 1, well, we have to create coronal laxity in extension, and you need to lengthen the primary and the secondary stabilizer in extension. LCL, popliteus, and posterior capsule is very important. Next. So when we do a release, Krakow and Whiteside work on this. When you cut, well, they were cutting in their study, the LCL, no big change. You can see here, it's really not big change in flexion, in extension and in flexion. But if after you cut the popliteus, well, in extension, not too severe, but in flexion, huge, you have a huge gap. It's a huge laxity. So popliteus should be preserved, and it is an excellent secondary stabilizer. Next. So when we plan the bone cut, it's very important to look at the medial compartment because it will be the reference for the stability. And then you will draw your axis, and then the perpendicular to the mechanical axis. Next. Okay. So the most frequent technique in a valgus knee is to do a pie crusting technique. So Henry Clark, and he did a study of releasing the lateral soft tissue by pie crusting. So they are in extension. They have the laminar spreader here, and they are underneath the popliteals, and they do pie crusting all around. And well, you start with the posterolateral capsule, and then, they get nervous, you know, they don't get the correction. And then they stab more anteriorly, and then suddenly, boom, it's laxity. And then they say, it's okay, we have done the release, and it's okay. But they know that they notice that at no specific attempt was made to transect the LCL. The structure was at least partially cut during this process. Okay, let's see what we do. Okay, so during surgery, we are in extension with the laminar spreader, and we do a total meniscectomy to see very well the popliteal tendon here, and then we palpate. And then it's tight, mostly on the posterior capsule. Okay, so you will pie cross your posterior capsule at this level. Next. Okay, next, it was surprise. Okay, and then you will pie cross your posterior capsule, and then if you are not yet corrected, you will pie cross in the area of the LCL, and frequently, you really see, when you pie cross several times and then jump, you are corrected, and you have the iliotibial band. So next. So you have a femur valgum. So to correct extraarticular femoral coronal deformity, you have to lengthen the lateral and the posterolateral structure. Well, that's fine in extension. You are neutral, but you have to pay the price of this lengthening of the lateral structures, and you get a space here. And so you will have to increase the femoral component rotation, and your soft tissues are weakened. So you may have to use a constrained knee for this reason, and you change the rotation. Next. So when it's the femur valgum is significant, we prefer to use a lateral approach with a flexion gap technique first. And so we excise the osteophytes, we release the iliotibial band here, and you see it's very simple in flexion because it's a coronal deformity. Next. So we do this, no release. We do the tibia, we do the flexion, the cut, and we are fine in flexion. AP cuts are parallel to the joint, to the transepicondylar line. Next. So we are here, and now we want to go into extension. So we want to keep, we want the condyle, the medial condyle is very important to be stable. So we report the posterior gap in the medial extension gap. Okay, let's go. So inflection, it's fine. We are here. Photo. We go. Okay, but in extension, it's impossible. So because we are too tight here. So we slide the lateral condyle and we will let it glide. Next. So it's here and it slide and we slide it distally, not posteriorly, only distally. Next. So we will do the osteotomy and we will allow this to go to slide distally in order to get full extension without changing the 90-degree stability. Next. So we do the osteotomy, a large osteotomy. It's strong bone. Don't be afraid because the lateral condyle is very strong in the geniovalgum. So we do a large osteotomy and which take the insertion of the LCL and the popliteus. Next. So it's not a simple osteotomy just when you remove the insertion. So with three proximally at this level, the insertion of the capsule. Next. And then with three posteriorly above the condyle, we release the posterior capsule. So it's a safe way to do a posterior release. And then we bring the knee in extension. So we slide this distally, and then we will trim the excess bone, and then we will be able to relocate the fragment, the osteotomized fragment inside the prosthesis. So the posterior stability is the same, and here we change. Next. And then it's very stable. It's simple because it's already stable inside. And we put two screws, or very, very rare to put a washer. And then we correct. And you see that 24 degrees valgus, and very easy to correct. And next. Okay, now geniovalgum type 2 with medial laxity. Well, in this case, I think we will agree that we have to do a hinged prosthesis. Next. But, okay. Also, when you have a geniovalgum like this, the lateral compartment is the same pathology as we saw, and it's bony wear. This soft tissue may be retracted. Okay, go. But what is very strange in the medial compartment? Well, the cartilage is normal, so you have a good reference for the medial stability. And at 90 degrees, so there is no deformity as was saying this cut. So this one, you will see, it's a very severe laxity medially, but there is no laxity at 90 degrees. And you see here, we are near to extension. There is medial laxity above the meniscus. So it's really between the epicondyle and the meniscus. Next. So Healy described a technique of advancing the MCL with bone recession, and he was able to correct this. Next. So look here at this patient. That's the one you saw, the medial compartment. She was stable at 90 degrees, but in a extension, she had this laxity. So we put the bone before cutting. So we had a reference of the medial compartment. So we had to free a bit laterally, and we had to do a medial condyle osteotomy, and we repair the MCL, and we put an augmentation of the MCL with a semitendinosis. and she was perfect. So I think when you have laxity at 90 degrees, it's finished. You have to do a hinge. But if you have no laxity at 90 degrees, I think you can augment and you can repair the MCL. Genuvalgum type 3, totally different. It's another disease because it's usually after HTO or after tibial fracture. The collateral ligaments are normal. You have just an extra articular deformity. If it's minimal, well, you can do a pie crossing of the lateral fractures. But if it's more severe, so then well, I like to draw this on X-rays. But look, if you have not seen this, well, that's a piece of bone. So if when you excite this piece of bone, you will have this laxity inside. So you will have a ligament laxity of a normal ligament, but just because you remove so much of the medial plateau, well, then you have laxity. So you should not do this. It's the same. So it's a coronal deformity. So go next. Okay, so here we do high HTO. We do it, and then we can do the joint, the total knee replacement. It's very simple, and this is very quickly. You can do it many ways. So I will show you a case. Right. You see here. Well, you see. You can't do this, but the guy did it. And next. Okay, you see. Well, you have a laxity due to the bone resection. He did a perfectly perpendicular cut. So he tried to reoperate with a thicker insert, with a more constrained knee, and you could see that it was open. So you have removed this. So you have always this laxity. So you put a bone augment, a wedge here in this side, so you have no more laxity, but you are in valgus, and then you redo the osteotomy, and then it's simple, and you correct the deformity. So when you have a small bony deformity, pie crossing, it is logical because it's a tibial deformity, but lengthening the posterior lateral soft tissue has limit, and the correction of the tibial deformity, I think it's better achieved by redoing the HTO and keeping the ligament strong. Thank you.
Thank you, sir. It was a very exhaustive
John
talk on valgus knee. This was a nice presentation on the osteotomy, because the osteotomy of the lateral epicondyle is very important. Everyone should learn that technique to do that in valgus knee to balance in both flexion and extension. Professor Brad, how commonly you do a IT band release? Because we know that IT band is a major stabilizer of the lateral part. So how commonly we need a IT band to be released?
Well, for me, when I have a severe varus and a patella problem, I do a lateral approach. So it's not a problem. And but you can do it with pie crossing. It works also.
Yeah, but we should do at the first instance, or we should keep it for the last release?
Well, you palpate. You palpate underneath the popliteus and you go anteriorly. Yeah.
Professor Han, you can put your slides on.
Yes.
So any questions, sir, Dr. Rajiv, on the platforms?
John V, you have explained the genovalgum so well that I don't think that we have many questions on this. John V has rightly mentioned that if the flexion is okay, then you can correct the genovalgum without a constrained implant. I think that is the important message.
Well, I think it's very important to keep the ligaments strong.
Right.
Professor Han will be presenting on preventing patellar complaint in total knee arthroplasty. Professor Han, please.
Yes, thank you for having me here. Dr. Paddy, really nice to see you.
Thank you, sir.
My topic is preventing patellar complaint in total arthroplasty. So, all know the patella plays crucial role in extensor mechanism function because it's anatomical pulley, and it increases the strength of quadriceps up to 50%. So, but patellar femoral complication occurs in up to 10% of primary TKR and responsible for up to 50% of all revision procedure. These are the common issue in total arthroplasty, patellar issue in total arthroplasty, resurfacing or not, and many patellar complications. So I'm going to touch with first with the resurfacing issue. So whether resurfacing or not is still on debate. There are many literature about that. If you look at the randomized clinical trial, so there are pros and cons. Some paper says no significant difference in between resurfacing group and non-resurfacing group, but the others say the significant higher rate of anterior knee pain without resurfacing. And if you look at the meta-analysis, some meta studies say there's no difference in anterior knee pain and satisfaction, but fewer additional surgical procedure with resurfacing group. But recently, more meta-analysis prefer resurfacing. If you look at this paper, the patellar resurfacing could reduce the occurrence of the reoperation and noise and increase KSS. And so also recommend patellar resurfacing. The other study says the patellar resurfacing total arthroplasty have performed better than non-resurfacing total arthroplasty in terms of KSS and HSS, and lower secondary operation and revision rate. Similarly, the higher risk of reoperation after non-resurfacing procedure. So for me, my practice, I always resurface the patella except extremely thin patella, but still on debate. Let me show you one case. So 77-year gentleman came to me with this X-ray. He complained about anterior knee pain, aggravating, up and down heel working. He underwent total arthroplasty 15 years ago at another hospital. You can see the severe attrition of the patella. And if you look at the intraoperative X-ray, you can see the severe wear of the patella. And I resurfaced it. And anterior knee pain was subsided. Patient was happy. 6 months. This is a picture 6 months after the surgery. But if you look at the literature, secondary resurfacing of patella usually shows unfavorable result. Only 40% of patients reported some improvement, and complication rate is considerably high at 30%. And current literature suggests anterior knee pain is multifactorial and may not be addressed by secondary resurfacing. So we have to be careful, and we have to discuss this matter with the patient before surgery. And I'm going to talk about patellar complications. Because of time limitation, I would like to focus on unstable patella. These are the long list of patellar complications: unstable patella, clunk, fracture, extensor mechanism disruption, osteonecrosis, and impingement on prosthetic trochlea, and unexplained and explained anterior knee pain, and component wear and loosening. A long list. For understanding the unstable patella after total arthroplasty, understanding the cause, etiology is very important. Most commonly, the femoral, tibia, and patellar component malposition is the main cause, and limb malalignment, especially bigus alignment after total arthroplasty, is a cause, and prosthetic design effect and improper patellar preparation is one of the cause, and soft tissue imbalance. So understanding the etiology is very important because it can help the surgeon to prevent patellar instability. So let's talk about component malposition first. Malposition of the femoral component tibia, and patella component causes patellar instability. And this is the predominant cause of patellofemoral instability in total arthroplasty, especially interrotation and medialization of femoral component cause the patellar instability. It's very common in knees with hypoplastic lateral condyle, which means the valgus knee, which may cause the internal rotation of femoral component and may cause the lateral subluxation or tilting of patella. And next one is limb alignment. So overall limb alignment, more than 10-degree values may cause the patellar malalignment, and femoral component position in more than 7-degree values increase the Q angle, and thereby the lateral vector of the quadriceps muscle increases and may cause the lateral subluxation of the patella. And pre-op severe varus alignment and consequently extensive MCL release is a risk factor for patellar instability. Look at the component design. Recently, contemporary totality design, most of contemporary totality design are patella-friendly design. They have patella-friendly trochlea, which means the laterally oriented trochlea like this, and high enhanced lateral fringe and deep trochlea groove. If you look at the Inzal Burstein, which was used in nearly half centuries ago, if you look at the axis of trochlea, it's straight, not laterally sloped. So big difference. But nowadays we don't have to worry about that much because of almost all design adopt this patella-friendly trochlea design. And improper patella preparation is one of the major causes of the patella instability. Asymmetric patellar resection or overstopping of patellofemoral joint, which means the insufficient femoral anterior skim cut and thicker patella, and the femoral component overstuffing also increase the retinacular pressure and may cause the lateral tilting or subluxation of the patella. Soft tissue structure also can lead to patellar maltracking, characterized by tightness of lateral retinaculum and weakness of vastus medialis muscle. Is common in long-standing severe valgus deformity. So let's talk about the prevention of patellar instability. So several basic technical guidelines must be followed to achieve patellofemoral stability. So most important thing is back to the principle. The proper femoral and tibial component rotation is most important, which was already touched by the previous speakers. And for that, we use the anatomical landmark. Like I personally rely on the Y side line most, and then the transepitular axis. I don't believe the posterior condylar axis that much. And tibial component rotation was also important. So we use the Akagi line and anterior cortical line. It's already touched by the previous speaker. So rotational alignment and femoral and tibial component is extremely important for patellar instability. And restoration of neutral mechanical axis is also crucial for instability, patellar instability. And the patellar component preparation is also important. Patellar button should be placed on medial portion of the patella. And there's a paper, medialization reduces the incidence of lateral retinacular release. And the production of patellar thickness is important. So I measure the patellar thickness before and after the implantation. So after implantation, the thickness of patella should be equal or less than the original thickness of patella. Intraop assessment with trial component is also very important. We use no-sum technique or single stitch technique or towel clip technique. If there is some lateral tilting or subluxation of patella was observed during this procedure, we need to check from A to Z, from the component rotation and soft tissue balancing, and we need to check everything. So this intraop assessment of patella is very important. So let me talk about the management of patellar instability briefly. patellofemoral instability is managed on the basis of its etiology. Precise cause of instability must be identified and corrected. That is very important. Let me show one extreme case of mine. So my junior doctor referred this patient to me. Actually, it was the original X-ray of the patient. You can see the laterally subluxated patella. Laterally tilted or subluxated patella before surgery is a major risk factor for patellar instability after total arthroplasty. Bius knee deformity, you can see. In axial view, you can see the completely dislocation of the patella. CT scan, MRI scan. And my junior doctor performed surgery, looks good in AP and lateral view, but and 6 months post-operatively, patient complained about the patellar subluxation like this. And then he referred the patient to me. If you look at the patient before surgery, you can see the subluxation of patella, which means the lateral instability of the patella. After exposure, same. Patella is subluxated laterally when the flexion of the knee. So in pre-op planning step, it is very severe, and the patella alignment was not good. So I planned the proximal and distal realignment. So the first I do lateral retinacular release and lateral capsular release, but the subluxation was not corrected. So I do distal realignment, the tibial tuberosity transfer, sliding transfer, and to medial side, and the medial capsule application like this. And then I check intraoperatively, and then the patella was stable. Okay, proximal and extensive lateral retinacular release and extensive capsular release and medial leaping and tibial tuberosity medial transfer. This is a post-op X-ray. You can see the screws to fix the tibial tuberosity, and you can see the good patella alignment. Now patient is 6 months after surgery. Our patient is happy. There's no more subluxation or dislocation of the patella. In summary, patellofemoral instability is a major complication after total arthroplasty and remains a common reason for revision surgery. And factors adversely affecting patellar tracking should be well understood and recognized. And patellofemoral instability is managed on the basis of its cause. Thank you for your attention.
Thank you, Professor Han. This was a nice presentation. Actually, patella, as much as we know, it seems like we don't know anything. So patella is a very difficult thing to manage. No consensus or anything related to patella. But sometimes, even after resurfacing the patella, while doing a trial range of movement, we see that the lateral retinaculum presses on the lateral trochlear edge of the implant. So in those cases, what extra we can do to decrease the pressure so that there should not be any anterior knee pain postoperatively? Professor Han, please.
You mean the intraoperatively or the postoperatively?
Intraoperatively, we see the lateral retinaculum presses.
Release.
It happens usually. Lateral retinaculum, while flexing, it presses on the femoral condyle.
Yes.
Femoral implant.
Okay. In the case, I do lateral retinacular release, but as I mentioned, the one of the major causes of the patellar maltracking is the malrotation, especially internal rotation of the femoral component or overstuffing of the femoral component. So I think precise rotational alignment of the femoral and tibial component is even more important than the lateral retinacular release. I think,
So
yes.
point well taken.
You rightly said.
Rightly said, because we have to have the rotation again. If the problem is there, we have to again go back and see the rotation of all the tibial and femoral components, and again come back.
Yes, I always say the patellar maltracking is a red flag sign of the rotational alignment. There's a
Very
problem.
right.
You have to check. Yes.
Very, very right. Deva, maybe in the interest of time, we'll have to move on.
Yeah, we'll move forward because of being late. I will request Professor Pradeep Punus, please. Professor Han, can you just stop sharing the screen?
Okay.
Professor Pradeep Punus will be talking on managing extra-articular deformity without navigation. Pradeep.
Right. Thank you, Paddy, for giving me this opportunity.
What's the time now?
Can you hear me?
Yeah, what's the time now?
Yeah, yes, please. Please carry on.
Right, okay. So the topic that was given to me was extra-articular deformities. Do you really require navigation for these kind of joints? Correction. I think, okay. So first of all, what is navigation? See, navigation is actually, we give the computer some information and the computer sort of figures out what's going on. So we have to tell the computer where, for example, where these various bony landmarks are. And then the computer decides that this is the mechanical axis, and based on that, I'm going to make my cut. Similarly, in the femur, we tell the computer externally where the center of rotation is. We show the computer where the landmarks are, and then the computer figures it out. So basically, it's a form of extramedullary alignment. Maybe more accurate, at least that's what the people who use navigation say. Yes, there are definite advantages, but it's a form of extramedullary alignment. So when you see this kind of an X-ray, can this be done with extramedullary alignment, be jigs or navigation? Definitely yes. So you do the templating, you put in your jigs, and this is an X-ray taken from one of Dr. Rajagopal's articles, and you can see that he has just used normal jigs and he's used the stem. So this was a form of extramedullary alignment, navigation or jigs, extramedullary alignment. Slightly different when you have a different type of deformity. I shared this some time ago in the IAA WhatsApp group, and I'd like to discuss this. So this is a significant deformity, and you can see a fracture following an osteoporotic fracture down below there. And you can see that the deformity there is 40 degrees. So now the question is, can we do extramedullary alignment for this? Well, if you're going to be doing extramedullary alignment, whether we're using jigs or navigation, what you see is that you'll have a huge medial defect there if you're going to be trying to correct that. Not only that, you can see there's significant medial tightness. If you want to try and release some of that, you can, but then you can also try and lower the tibial cut to try and release the tightness on the medial side. But invariably, you'll end up with a huge amount of laxity issues, and this is just not going to be possible. So you will have to correct the deformity with an extra-articular correction, probably some with a wedge osteotomy, and you'll have to do it. Now, how do you do this? You need to template this beforehand. So if you're going to be doing a cut, you want to make that osteotomy at that fracture site. So when you template, you find out where you may need to put a stem in. So if you're going to be putting the stem, you want to be putting in center. So you can see, if you want to make a preliminary cut and see where the center of that the tibial tray is. And then preferably under II guidance, you can actually put in your reamer till where you see where the deformity is. And at that point, you can actually make either a percutaneous or an open osteotomy, closed or open wedge, and then you pass a reamer on further more inside. And you can then, if you need to do a fibular osteotomy, you can do the fibular osteotomy. But basically now it becomes like any intramedullary alignment issue. And you can see that you can go ahead and make your cut, and the soft tissue issues are a lot more easier to manage. Now, in this interim period, if you can just keep if there is a differential movement between the proximal and the distal segment, some surgeons may decide to use a plate temporarily or permanently, depending on what it is. But very often you can just simply use an intramedullary jig and you are able to make your proximal cuts. In this particular situation, I've actually used a plate primarily because the stem that was used was too long or too short. If it had been a longer one, it would not have been necessary. But you can see that just with intramedullary alignment, this has been done. So the question was not really navigation or not navigation. The question was intramedullary or extramedullary alignment. Now, if you look at this particular X-ray, for example, you can see there's a deformity there. Where do you make your correction? Now you drew your templating, and then the question that you have to ask is, can you release enough on the medial side to correct that? Now that will also depend on how much of laxity there is on the lateral side. So you need a standing X-ray to check that out. A lot of the previous speakers have already alluded to this. Now here, you can go ahead and try and take off some of that extra bone, the medial osteotomy, and you can probably get it out straighter. So in this particular situation, yes, we've done that intra-articular correction, but we've used an intramedullary alignment. And the reason why we've done that is because we've used a stem. So it is not navigation, but an intramedullary alignment. There was no need for a navigation for this particular X-ray. Occasionally, depending on, again, on the templating. See here, you can see that if you're going to be using a stem, the stem is very much offset. You must take, of course, into consideration what Anup had said about where you place and how you put the stem. But you can see there is an offset. So you must be prepared with an offset stem, because otherwise you'll find that the whole tibial tray will be sitting in the wrong place, because it's all dependent on where you put the stem. So in this particular situation, of course, we have used an offset stem. And this is why templating is important. Now the question is, how do you decide whether you're going to make this, you see this deformity, can you correct it intra-articularly, or do you require something extramedullary? That's a question that's often asked. Preoperatively, how can you determine? So this is the paper by Wong long time ago in 2002, where he said if you draw that axis upwards from the distal tibia, if it cuts the tibial plafond, then you probably can correct it intra-articularly. Whereas it goes outside the tibial plafond, then most probably you'll have to do some sort of extra-articular alignment. While that may be true in most cases, that is not always true. I think templating is what is more important. For example, if you look at this particular X-ray, you can see that the line goes actually through the plafond. But when you do the templating, you realize there is absolutely no way, even if you're going to be taking off all that medial tibia, there's no way that you're going to be able to release that medial soft tissues there. The two options that you have, one is, of course, you can do a medial, you can see that what's tight is the medial side. So you can either do a medial epicondylar osteotomy and try and release that, but it's probably not the best idea. Better than that would probably be to do an extra articular correction and get it straight, and you can go ahead and put your stem in. So that's a decision that you have to make. Yes, Wong's philosophy can help, but I think templating is also very, very important. The same thing applies in the sagittal plane as well. It's templating that is important. So when you have a deformity, you've got to decide where you're going to be putting the stem, but more importantly, you have to be able to choose an implant that will be able to fit into that area, and you might have to use an offset stem. So in this particular case, an offset stem has been used, but you can see in the previous case where Dr. Rajagopal had done without the stem because it was a fracture, he's managed to keep it, but it is choice of the stem that was necessary. Choice of the implant and that the size of the keel, which is very important here. Now it's templating that is important. What they say is that generally angulation of more than 15 to 20 degrees in the sagittal plane will invariably require an osteotomy. Now the femur, it's slightly different. Now in the tibia, we normally use an extramedullary jig, but in the femur, what we normally do is we use an intramedullary jig for our alignment. So we put in the rod there and then we calculate how much of valgus we need to make, and we go ahead and make the cut based on the intramedullary alignment. Now in this particular X-ray, for example, you see that, okay, it looks okay on this particular X-ray, but when you look at the patient, you can see that even after the knee replacement, it's still very bored. I think there have been a lot of similar X-rays by the previous speakers, and you can see that the obvious reason was because he used an intramedullary jig in this anterior bowing. And as already been mentioned by the previous speakers, when you put in your intramedullary jig, you have no idea where you start. And you can see that it's going in a totally different direction of what you want it to go. And you can see that the angle that you end up can be 14 degrees, huge, and really cannot use your intramedullary jig for alignment. And I think this is where you need some sort of extramedullary alignment method. And navigation is probably one of the better ones in this kind of situation, though you can use other methods, which I will allude to later. But this is one situation where navigation is definitely better. So you can see that here we have done the left side. I'm not going to go into how we did the revision for the right side, but basically we have used an offset stem starting much more laterally, and you can see that the right side too has been corrected now. And you can see that the knee is much more straighter and the patient is much more happier. We have used an extramedullary alignment for this because we could not use the intramedullary alignment. And that is a question that we are going to be asking. Now, the extramedullary alignment, this is a non-navigation method which has been described, where you put two metal rods or buttons around where the hip is. And then when you're doing the hip the knee replacement, you use an extramedullary alignment jig like this, and you make sure on the x-ray that it goes on that particular dot. One of the previous speakers had alluded to a hammer at the region of the hip, but this is probably a more accurate method of trying to find out where that mechanical axis is. So this is poor man's navigation, as you can see. The question was, it is an extramedullary alignment. Wang did describe this as well when he described his paper. Again, it's templating, which is important. When you make your cut, for example, in the this one here, you can see that the collaterals are not damaged, so you can do intra-articular correction. Whereas in this particular one, you can see the collaterals are being damaged, again, based on templating. And so you will almost definitely need to do an extra-articular correction rather than trying to correct it intra-articularly. Mind you, as what the previous speaker said, it's the soft tissue laxity is also to be taken into account when you're thinking of making these cuts. In this, obviously, you can see that when you do the templating, your collaterals are obviously going to go. You will have to do an extra-articular correction. And you're doing your TKR, whether you're doing it at 1 stage or 2 stage, you can decide, but you will almost definitely require extramedullary alignment. You cannot use the intramedullary alignment because the implant will be there. So that's basically what has been done. So 1 stage or 2 stage, depending on whatever you're comfortable with. This is another one. Now, if you see there's a deformity there, but when you do your templating, you can do all the correction intra-articularly. But the question again, would you use navigation? Or shall we say, would you use extramedullary alignment, or do you use an intramedullary alignment with the rod? I think when you have a deformity, it's quite difficult using the intramedullary rod. So I think when you have better options available, I would personally use an extramedullary alignment, navigation, or x-rays and jigs. That's up to you. In the sagittal plane too, you can get a correction of about 10 to 15 degrees if the deformity is 10 to 15 degrees, but otherwise you probably will require an extramedullary correction to get that straighter. So the key question here is not really navigation or not navigation. The question really is intra-articular correction or extra-articular correction. And I think templating is really the key. About 30 degrees in the coronal plane and about 15 to 20 degrees in sagittal plane can be sort of corrected intra-articularly in general, but that's not necessarily always the situation. And in the tibia, if you're using a stem, obviously you want to use an intramedullary alignment. If you're not using the stem, you can decide what kind of alignment you want, navigation or jig. The femur, because you have a deformity, it's quite difficult using an intramedullary jig. So invariably, you'll have to use an extramedullary alignment. Whether you want to use jigs in X-ray, or whether you use navigation, that's your choice. Thank you.
Thank you, Pradeep. I think it's a very, very well done talk. Can I request Rajesh, you to share your screen? In the meantime, we may have one question for Dr. Pradeep Punus.
Any questions from any of the faculty for the interest of the young surgeons? For Pradeep, Dr. Pradeep. So Dr. Pradeep, any rule of thumb you will just conclude that any rule of thumb for any deformity of the femur, how much deformity of the femur we should think of correcting intra-articularly, or how much deformity in the tibia will try to think of correcting intra-articularly?
Yeah, I think a lot of it depends on the templating. So it is very important that when we template, we see what's happening to your collaterals. If your collaterals are going to be involved in your cut, then definitely you'll have to do an extramedullary alignment. But if when you're doing a templating, if you feel that your collaterals are going to be saved, then you probably can do it intra-articularly. Of course, your soft tissue laxity also plays a role in your decision.
Yeah, very right. The pre-operative templating is very important. Can we request now Dr. Rajesh Malhotra to start his talk?
Thank you very much. Good evening. Thanks, Dr. Rajiv. Thanks, Dr. Padi. We are going to talk about something which it is everyday thing, yet it's not so easy to understand. Why is a flexion deformity underrated? Because its importance often is not realized. It's often not diagnosed, and particularly the magnitude, and many times the surgeon is not clear about how to treat. And then there's a question about how they will behave post-operatively if left untreated. So flexion deformity is important because it causes shortening of the limb, abnormal posture of the neighboring joints, inefficient locomotion, and increased energy expenditure. And redundancy of the extensor mechanism will be caused because of long-standing severe deformity. And as we all know the gait cycle, we know that the gait cycle is affected in terminal swing and stance phase when there's a flexion deformity. It causes increased recruitment of quadriceps mechanism with accelerated quadriceps fatigue. So this is a paper which showed how the hip knee spine syndrome occurs when there's a flexion deformity, and the relationship keeps on getting more and more abnormal with increasing flexion deformity and is restored back to normal with knee replacement once the flexion deformity is corrected. Now, there are papers which show that the high preoperative flexion deformity more than 10 degrees correlated with postoperative flexion deformity at the end of 1 year. And there are also studies which show there are poorer outcomes in patients who had preoperative flexion contracture of more than 5 degrees, and a preoperative flexion contracture was determinant of the postoperative flexion contracture. So the other factors other than the preoperative flexion contracture are male sex, advanced age, inflammatory disease, post-traumatic etiology, and Parkinsonism disease. So this is a paper which showed that the men have higher flexion contracture because of the difference in muscle strength, elasticity, and soft tissue characteristics. The pathophysiology of flexion deformity is it can occur because of progressive arthritis and lack of physiotherapy, recurrent effusion preventing full extension, pain inhibiting movement of the knee, posterior osteophytes stenting the capsule, the contracture of posterior capsule cruciate ligaments and hamstrings, intra-articular fibrosis and adhesive capsulitis, inflammatory erosion of the posterior femoral condyle, so-called chicken drumstick appearance, and the anterior osteophytes in the tibia preventing the full extension. Now, this paper on BMC musculoskeletal disorder showed that the goniometer is unreliable. And for those of us who use the computer-assisted navigation, it can actually diagnose flexion deformity better and more accurately as compared to the normal observer. So something which looks almost slightly bent, maybe as much as 8-degree flexion deformity when you check it on the navigation. And of course, the magnitude of the flexion deformity matters. Grade 1 is less than 15 degrees, 2 is 15 to 30 degrees, and grade 3 is more than 30 degrees. So you must assess the passive correction of deformity and associated varus or valgus deformity. The real magnitude of flexion deformity is apparent after anesthesia. So this is a 64-year-old male with osteoarthritis both knees who presented with more than 30-degree flexion deformity on both sides. And this is the same patient after anesthesia before surgery could be started. There was no flexion deformity. So real flexion deformity is assessed after anesthesia. And then, of course, must remember that the surgeons often underestimate the flexion deformity. Now, the management of flexion contracture intraoperatively depends on the soft tissue balancing. And like Dr. Harish Bende said, that you must make the proper cuts. And because you can't compensate for bad cuts by the soft tissue releases, and you want to achieve stable and symmetrical flexion and extension gaps. And if you don't release the soft tissues and do erroneous bony resection, then you will have an inappropriate joint line. Ramnik said that if you cut too much of distal femur, you have elevation of the joint line, patella baja, and even mid-flexion instability. So the steps for success are follows. So I'll just go through them. The first is, of course, you have a medial exposure, osteophyte remover, the posterior capsule, and soft tissue release. The second is that, the osteophyte removal is very important, as you can see here in this. And then, of course, the distal femoral resection, you can do an additional 2 mm proximal resection. Now, if you are a CR knee user, After 2 millimeter, you can't resect any more distal femur because then the PCL becomes tight and it will not allow you to flex the knee. So if you need more than 2 millimeter proximal resection of the distal femur, additional resection, then you should switch on to the PS knee or UC knee. So before that, you first must release the posterior cruciate ligament and or do all the soft tissue release of the posterior capsule and see. But you should have then the PS components if it's required. So release the posterior capsule, posterior osteophytes, and soft tissue release. That's extremely important. And there's something called the cortical ring sign. You look at the posterior after the posterior condylar resection, you'll see a cortical ring here, which means that there is osteophyte behind there. The posterior osteophytes must be removed before doing any further releases or before doing additional cuts. So posterior osteophytes must be removed before managing soft tissue tension is what this paper also said. Now the PCL must be released if it needs more, like I said. And then of course the repeat cut if you have not achieved the sufficient extension and the extension space is still limited. You must remember that with increasing resection of the distal femur, you keep on getting a rise in the joint line, but you also keep on losing bone from the posterior condyle, and the loss of the posterior condylar offset by itself is another malady which causes the instability and the reduced movements of the knee. And then of course you can release the capsule posteriorly. The soft tissue release has to be done. The posterior capsule has to be released. And if you get instability after doing all the releases, you have to use a constrained liner. And if the instability persists, or if both collateral ligaments have to be released to achieve full extension, a rotating hinge design has to be used. So to just quickly recapitulate, for a mild flexion deformity, you will not need additional cut. Just remove osteophytes and do soft tissue releases and you'll be fine. In 15 to 30 degrees, you can do a posterior soft tissue release. You can do the subperiosteal release of medial or lateral gastrocnemius. You will find them here. If you hyperflex the knee, you can do that. And you can, of course, do the additional cut. So posterior medial release is also important. And in the severe flexion deformity more than 30 degree, you may have to do up to 4 millimeter resection of the distal femur. But if you do more than 4 millimeter resection, you'll get elevation of joint line, patella baja, altered patellofemoral kinematics, and the mediolateral instability. So severe deformity more than 30 degree, you may have to release the hamstrings, and that can be done percutaneously, but you should be careful releasing the biceps femoris as to not to damage the nerve. In a very severe deformity more than 60 degrees, you can do a staged procedure. In the first stage, you release the hamstrings in the posterior capsular release, and then you do the casting to allow stretching the posterior structures, and you can do it in the second stage. So that's a summary of these steps. So technical tips are, if you're using a posterior cruciate retaining processes, not more than 2 millimeter additional resection. Grade 2 and grade 3 will need a cruciate substituting or the posterior stabilizing. And if there is a severe contracture, you must balance flexion and extension gap. You can upsize the femoral component to stuff the flexion space, or you can use a constraint prosthesis. In grade 3 contracture, you may have a lax extensor mechanism, so you may have to do the distal and lateral advancements of the vastus medialis obliquus to get this strength back. And then, of course, you have to pay attention on the post-op rehabilitation. Now, there was a talk about flexing the femoral component. If you flex a femoral component more than 3.5 degrees, you will have a 3 times higher risk of post-operative flexion contracture. So you should be careful when you are flexing the femoral component. You may be able to stuff the flexion space, but it comes at a price. The excessive posterior condylar offset. So if you have removed very little bone from the posterior condyle, it can also lead to the flexion contracture. So these are the intraoperative errors. Post-operatively, you must control pain, give cryotherapy and rehabilitation. There's no role of splintage. The contralateral shoe lift must be given if you want to avoid the recurrence of the flexion contracture. Particularly many times when we do unilateral and the other knee is deformed, the patient will develop a flexion contraction in order to move better and equalize the limb length. So it helps to do a shoe raise on the opposite side. The successful correction of the flexion contracture has also been done with botulinum toxin in patients with Parkinsonism disease. So for the rheumatoid, there is a rule of 1/3 for flexion deformities which are very high, like more than 40 degrees, which means that 1/3 is corrected under anesthesia. 1/3 is corrected intraoperatively, and 1/3 is corrected in the post-operative. About the outcomes, there's a significantly decreased post-operative flexion contracture if you use computer navigation. This is the same patient I showed you with the flexion deformity after correction on the table. And the patients who have preoperative flexion deformity, they can show improvement up to 10 years after this, after TKR according to this paper. But this is a flawed paper because almost 40% of patients were lost to follow-up. Another paper said that at the end of 4 years, the patients did develop the flexion contracture, which had developed after the surgery. Again, only the patient with grade 1 and 2 flexion contracture were included in these patients. If somebody develops a new flexion contracture after total knee replacement, these authors say that it can get corrected and the outcome can be comparable to those who did not have a flexion contracture before surgery. So to conclude, the presence of fixed flexion deformity has significant clinical implications on the quadriceps mechanism of action before or after TK. Diagnosis and magnitude of flexion deformity is often underestimated. Treatment should be tailored depending on the severity, and aggressive extension exercise program is encouraged to prevent recurrence of deformity and extension lag. Thank you very much for your attention.
Thank you, Professor Malhotra. It was a nice talk and very self-explanatory and exhaustive. If any questions are there, if not, we'll move forward. I think because of lack of time, we'll move forward. Thank you, sir. Professor Abhay, please put on your slides.
Can you see my slide now, Dr.
Yeah,
Devbrat?
yeah.
Yes,
You
yes.
can-
Thank you,
you'll
Dr.
see all
Rajiv, sir.
indications
Thank
of
you,
streaming.
Devbrat. Last man standing. So I'll quickly run through this program. So when we're doing a total knee, obviously we're trying to recreate a stable joint by accurate positioning and orienting our prosthesis, and we are trying to mimic the normal joint kinematics. But sometimes we need to do more than just the regular reconstruction because of bone defects, because of stress fractures, and because of osteopenic bone, which is a reconstruction aided by the tibial stems. So the basic question that we need to ask ourselves is that what does a stem do? Well, a stem essentially is a trade-off in trying to get more mechanical stability at the cost of stress shielding. And when we talk of mechanical stability, we're talking of increased resistance to shear at the level of the tibial joint line, in reducing the lift-off, decreasing micromotion, and doing a balanced load transfer to the underlying cortical bone. And the few key concepts when we're thinking about stems and how to do them and which ones to use are the concept of zonal fixation, which essentially is a revision concept, but we extrapolate it, and it works extremely well in identifying the indications for stem for bone defects, stress fractures, and for deficient bone stock. And the other concept that we need to remember is the concept of how a bone remodels in response to the stresses and strains of a valgus or a varus knee, and thereby defining the geometry of the stem, the material to be used, cement to be used or not to be used, and the coverage issues for the proximal tibia. But as a disclaimer, the literature has enough data to speak on both sides, and there are no ideal indications as with respect to proper stem lengths, to the optimal stem diameter to be used, the fixation methods, and all of these still remain a controversial statement. And as such, there are no evidence-based guidelines as to when exactly to use a stem, what length and diameters are ideal, and whether or not to use cement or not. So we have extrapolated data from this beautiful paper from Ridin, Morgan, Jones, and team, where the basic concept is that optimal fixation is needed in at least 2 fixation zones. And when you talk of fixation zones, you're essentially talking epiphysis and articular surface, a zone 2 metaphysis, and the diaphysis. So in a normal knee replacement, when you're trying to have a reconstruction with fixation into the articular surface and the metaphysis, where you have an increasing defect intra or an extra articular, and you have a stress fracture or osteopenic bone, you're essentially looking to connect zone 1 with zone 3, and thereby get your stability and resistance to shear at the level of the tibia. And the basic indications could be osteopenia, which could have medical treatments, and then you could require the use of stem extensions, depending upon the kind of defects, depending upon the kind of bone loss. If you come to periarticular defects, essentially for primary situations, you have an INSAL's classification which talks of central defects and peripheral defects, and INSAL talks about how and what to do. So in a stage 1 defect is one where you needed a stem alone, and the stage 2 and the stage 3 were defects where you might need a stem augmentation. But the real indicator and the advice comes from a revision classification, where the more defects you see, the more you realize how to deal with them. And the predominant categories that one comes across are mild defects with osteopenia, where one needs to use stems, moderate to severe uncontained defects where you have a metaphyseal bone loss either on the femur side or on the tibia side, and severe uncontained defects with deficient metaphyseal bones where again could happen on the femur or tibial side. So these are the indications where predominantly one might need to use a stem. An example, classical example of a subarticular defect in a very severe osteoarthritis knees in a 55-year-old male was treated with impaction bone grafting for both the femur and the tibia, and the reconstruction was protected with the use of a stem to obtain and maintain the balance and the fixation of the joint. Another case where we had more than 5 less than 10 millimeter uncontained defects combined with a contained defect, where on one side the defect required impaction bone grafting and the other side reconstruction. And to protect this fixation, it's a good idea to use a stem and thereby having a secure fixation and a stable total knee. Another case where we had an uncontained defect more than 10 millimeters, osteopenic bone, very severe defect. The problem was the defect was uncontained, and one had to do a medial epicondylar osteotomy to balance out this knee. And again, it's a good idea to have a secure enough fixation and get a good fixation in zone 3 in addition to what we're doing at the level of the joint. So what is basically happening? There is another concept as to why and which stems to use, and that essentially requires us to understand how the bone remodels and the Wolff's law in response to stress and strain. So the mechanical axis essentially is the best predictor of the peak adduction moment that is happening during the gait cycle. And where you have increasing severities of osteoarthritis, you have increasing deformities and thereby increased strain patterns of the proximal tibia. So basically, if the strain patterns are between 50 and 1500 micromu epsilons, then you have a stable platform. But once you start walking less than 50, you start going into stress teething situations. And when you have more than 1500, the patient develops microfractures and deformities, and more than 3000 develops pathological fractures. So here are case examples. Essentially, when you have less than 50, you have a stress pattern and an osteopenia developing in the femur. And again, when the deformity goes way beyond 1500, you start developing microfractures and metaphyseal deformities of the tibia along with bone defects. And more than 3000, these patients often present with the stress fractures in association with the osteoarthritis of their knee. And a beautiful article by Dr. Mulaji and Shetty, basically classifying different types of periarticular stress fractures as intra or extra-articular, with dividing them again into malunited and ununited categories. And most of the extra-articular fractures that we see essentially are either ununited, malunited, or those with an acceptable angulation of less than 5 degrees. So here are certain case examples. A 78-year-old stage 4 OA, severe varus flexion deformity, had an extra-articular deformity. Again, as you say, the question is not just navigation, it's intramedullary alignment. And you do a fixation and get a stable platform connecting the zone 1 and zone 3. Sometimes you might need to use an offset stem in these patients, or you might need to undersize the tibial component, making sure that you're not really resting on cancellous bone, but you're actually resting on cortical bone. Otherwise, you tend to sink and have secondary deformation. So that is something that one needs to take care of. Another patient, similar situation, treated appropriately with the stems and fixation involving the zone 1 and the zone 3. So the next question that one needs to answer and ask is, what is the optimum length and the fixation that one needs to use in a stem? So the basic premise of using stems is that one wants to decrease micromotion at the level of the total knee prosthesis by increasing stem length, the stem diameter, and providing an optimal canal filling ratio. So where you have a metaphyseal defect, short cemented stems work well. in contrast to where you have a very deficient diaphysis where there is a significant metaphyseal damage, where you might use a long press width stem with proximal cementing or augmentation of the metaphysis with metaphyseal sleeves or cones, or situations where the metaphysis is damaged, but not so much damage where just the long press width stems would do. But the basic premise is literature fails to identify what is the ideal length of stem to be used in these situations. And probably the understanding which defines the length of stems today is that it has to be a composite of stem length and diameter given by the canal fill ratio. So the take home is stems essentially are a trade-off between trying to get mechanical stability in exchange for stress shielding. And what we mean by mechanical stability is that we have increased resistance to shearing off at the level of the tibial base plate, cement, and bone, a reduced liftoff, decreased micromotion, and a balanced load transfer to the underlying cortical bone. Literature fails to provide the ideal length, diameter, material, and fixation consensus on stems. The probable answer is to get an optimal canal fill ratio, and the stems basically need to be used when you have osteopenic bones, bone defects, stress fractures, in order, and in times when you're using a bone grafting or you're trying to protect grafted defects. Thank you for your time.
Thank you, Abhay. It was a nice presentation. The thing what we come to know that in bone defects, we have to think of using a stem. I will ask other faculty if anybody has any experience of not using a stem and using a stem for a long-term period follow-up for patients who are having a bone defect. Anybody in the faculty, Dr. Anup, Dr. Vijay, Dr. Haris?
There were the use of very well explained, Abhay, about the use of stem. In my practice, I try that if there is an instability, if there is a bone defect which we are filling up with the bone graft or the metal wedge, and then probably the stem is very, very much important. For osteoporotic bone alone, probably it may not be as much needed. If you have a good balanced joint and you have a good, well cemented joint. What's your opinion on this, dear?
So the take on this is that if you put in a long uncemented stem, that in a way is going to cause stress shielding in an osteopenic condition. So you are actually, if you have a long stem, if you have a very thick stem, and if you have a stem which has a cortical chatter in zone 3, which is the diaphysis, then yes, you will have a stable platform, or even if you put in a stem, but then it tends to cause secondary osteopenia, which can cause secondary collapse, subsidence, and problems. So the basic decision is not just osteopenic conditions, but those osteopenic conditions which are associated with defects, virus, and other deformities as well.
Very right. Yeah.
There is a question.
Can I ask a question, Abhay? Now, when you reviewed the literature, any specific criteria on use of stem in high BMI patients, patients who are extremely obese, and we are doing a primary knee, they don't have any defects, but just because of their body mass index.
So the high body mass index is not per se an indication for using a stem. A stem essentially is used where one wants to protect the fixation or the graft or the defect reconstruction, or if one has a slight element of instability because of a defect, and one is trying to prevent the shear at the levels of the tibia, cement, and the bone interface, but not really indicated for a high BMI.
Would that stress not increase when there is a high BMI index, at the cement bone interface on tibia, when the patients are extremely obese?
So if one leaves behind an unbalanced knee, which is going to cause a varus or a valgus moment, that with or without a stem is going to be a recipe for a problem. But if you have a balanced knee, then obesity per se does not require stem fixation, unless you have associated defects or soft tissue instability in addition to just the osteopenia.
Thank you, Abhay. It was a very nice, fruitful discussions on the basics of knee arthroplasty. With this, I will hand over to our president, Dr. Rajiv Sharma, for the concluding remarks and the vote of thanks.
Thank you, Deba. I think this was a very well attended program, and the faculty had given a wonderful presentations for the difficult problems, simple issues, the right surgical techniques, and we'll just give you a take-home message for our younger colleagues. Our important thing is that important considerations should be pre-operative, per-operative, and post-operative. You must have the patient assessment, as has been discussed, the good operating environment. The assessment has to be with the long leg x-rays, psychological assessment, justified expectations, and the gait assessment. And Vijay has said very well about the gait assessment. If it's a waddling gait, it's a different issue. If it's a lateral thrust, it's a different issue. And this has to be explained and understood very well. The operating environment remains very important for a successful knee arthroplasty. Adequate exposure is important. It's better to have the bone cuts and do the alignment proper. I always feel that it's a better idea to recheck whether your distal femoral cut or the tibial cut is correct, and which is very simple to check it up, and then the right kind of the balancing of the joint, the right alignment, the posterior offset and posterior clearance remains very important. The stable joint remains a very important thing. You must feel that middle collateral ligament, is it tight or is it the right stability? You make adjustments if needed. Even if you're not using a navigation, you can use these certain simple tricks which will help you in an easy way to balance the joint. One simple example, having the extreme deformity. Release on the posteromedial corner, and the sequential release, which is very rightly explained by Vijay, and undersizing the tibia if it is needed. Like in this patient, which is having the extreme deformity, even after so much of release, you can see that the lateral laxity still remains. It is not enough release. So friends, do the adequate release, sequential release, reduce the tibial size, tibial implant size, and once you do that, even a complicated case can be balanced very well, like you see in this patient. The final implantation is a well-balanced joint. And that's what you see. This patient on the next day of the surgery, having the good flexion and good extension and a very stable joint. Another patient at 1 month. Good cementing is very important. Skin closure inflection, skin incision is inflection, the suture line as the individual preference is. Pain control, which Rajesh has mentioned very well, is very important, which is important for the rehabilitation. What you see the next day or the second day, the patient should be able to flex and extend the knee on her own. That's what you see. And that is very important, that soon it should be. And then lastly, recognize the complications early. Like in this patient had the fracture. It was fixed. And you see, this is the 8-year follow-up. The joint remains perfectly fine. So with this, we end our clinical discussion on this, on how to achieve a happy joint. The next of our series of webinar is next month, May 19th. The convener is Dr. Mrinal Sharma from Delhi NCR, Faridabad. He will be running a webinar on stem selection for a revision knee. Friends, to become the member of Indian Arthroplasty Association is very easy. Just go to our website and click on the member to how to become the member. You can pay it online and become the member. Present membership is 745. And lastly, I'll invite you to the Asia Pacific Arthroplasty Society as IAA member, where you will have the opportunity of becoming the temporary member of the Asia Pacific Arthroplasty Society if you are the new member of IAA, and having some concessions, discounts in the registration amount as well, which we will be sending you by the email Thank you so much for attending this webinar. I think this was a wonderful effort, Dr. Devabrata. It's very well done. Thank you so much. And we now close this session.
Thank you, sir. Good night.
Thank you. Good night. Thank you, everyone.
Dear, I think it was a little extended discussion, but I think it was a very important discussion.
Dr. Rajiv, may I speak?
Yeah, please.
Sir, actually, STEM selection and revision was covered in the last webinar by Abhay. So I think we were doing it on revision totally orthoplasty, and all the faculty